So good afternoon, good evening, good morning for those tuning in from around North America and Europe and beyond. Wanted to welcome you to this third day of our clinical cardiopulmonary physiology for the care of sick newborn course. Today, a very special session on challenges in neonatal pulmonary hypertension care. We have experts from around the world who are going to share insight. Each talk will be about 20-ish minutes. And just to remind everybody to put your questions in the Q&A. And after the 5 excellent talks that we have, we will be having a Q&A live session with all the speakers. And really, without further ado, I wanted to invite our first speaker to put his slides up. Really needs no introduction. Professor Amish Jain, who is a staff neonatologist at Mount Sinai in Toronto, and really the brains behind this entire 5-day symposium and all of the previous years. So Amish, take it away.
Just gonna share my slides. Right. Can you see it?
Yes.
All right. Excellent. Thank you so much, Phil. Hi, everyone. My job really today is to just kick off the meeting by talking about the basic physiology. Now, I've recently given a couple of talks on this topic, so if some of you attended those, then I apologize. There will be a bit of repetition. So hopefully this basic hemodynamic physiology sort of discussion will set the scene up for more informative sessions by the next 3 speakers who are going to talk about specifics situations. But I'm just talking in more in general. First of all, my disclosure: I do have an investigator-initiated research grant that I got from Mallinckrodt Pharmaceutical for setting up a national database of preterm infants receiving inhaled nitric oxide in Canada. Having said that, I'm not really talking about preterm use of INO, but nevertheless, this is my disclosure. Now, from a physiological perspective, what we really look at PPHN physiology as a failure of normal postal adaptation with a persistently high PVR, and that leads to shunting of blood from the pulmonary to systemic circulation, and clinically it presents to us as hypoxic respiratory failure. So this is how we tend to think about PPHN as a syndrome, and it's not just hypoxic respiratory failure, but it's in conjunction with a persistently high pulmonary vascular resistance, and which is important because that's what derives the shunt of blood from the pulmonary to systemic circulation. So I'm not going to talk too much about inhaled nitric oxide. We all know that that's a first-line therapy for hypoxic respiratory failure during transition in term and near-term infants. And the patients, at least these days, who have hypoxic respiratory failure, which completely resolves by giving inhaled nitric oxide, oftentimes are not that difficult to manage. But we all also know that a significant proportion of patients, ranging from 30 to 50%, depending upon their gestational age and underlying diagnosis, would often not respond. And what do we mean by that is that their hypoxic respiratory failure will persist despite our attempt to give them a pulmonary vasodilator in the form of inhaled nitric oxide. And it is those patients which actually become a bit of a challenge to manage for neonatologists in 2021, where we don't really have any direct evidence of alternate therapies, or at least not robust evidence. We have some evidence, but the management of these patients largely derive from pathophysiological principles. If one thing I can ask everybody who's managing these patients is that you don't have to follow what I or anybody else suggesting. There are many ways to do to skin a cat, but everybody who works in an ICU and looks after this patient must have a framework in mind. How you're going to assess and manage patients who don't respond to your standard initial treatment. And on that note, I think at least this is what I tend to follow a lot in clinical practice, and I'm sure Patrick is here. He and I worked together in creating this algorithm some years back, which I actually find very useful when I am looking at the bedside. is to understand what are the potential cardiopulmonary sequelae of having a persistently high right ventricular afterload. And it's just worthwhile just thinking about that for a few minutes, that you will have the patients don't have to have all these features, but they all can coexist, or some part of this can exist. And as this algorithm shows, that a high right ventricular afterload just by itself being can cause significant right ventricular systolic and diastolic dysfunction, which itself can cause pump failure, causing reduced pulmonary blood flow in the form of reduced right ventricular output. And reduced pulmonary blood flow will also present clinically as hypoxemia. So this actually can cause hypoxemia, acidosis, further worsening the VQ mismatch. Will also reduce the left ventricular inflow. So hence the LV preload will go down, which may, and not always, but may contribute to left ventricular dysfunction. At the same time, the right ventricular dysfunction by interventricular interdependence, using the mechanisms that a couple of days back Phil quite nicely showed, by shared myocardial fibers, among other mechanisms, can also directly impact the LV function. Now, it's important to note the role of the shunt, because this is happening during transition. A lot of these babies do have a PDA particularly and PFO still present, which in the presence of a high right-sided pressure would typically shunt right to left, quite significant volume. Now, this right to left shunting across the PDA can actually protect the right ventricle from failing because it offloads the pulmonary circulatory bed. Having said that, that will come at an expense of hypoxemia, because the blood that is going to shunt across the PDA will cause hypoxic mixture in the post-ductal region. So it can protect. It can also protect systemic hypoperfusion by actually maintaining systemic blood flow. So, but again, at the cost of reduced pulmonary blood flow. So there are patients, at least in my opinion, whose problem is too much blood shunting on the PDA and not going in the lungs, causing reduced pulmonary blood flow. And there are other patients in whom it actually is a beneficial to the patient by protecting the right ventricular function and system hyperperfusion. So you can have these phenotypes, these different phenotypes in different patients, where some patients have underlying cardiac dysfunction, both right and left, and reduced cardiac output, and others don't, and others tend to suffer from a right to left PDA shunt causing a problem, and others in whom it actually not a problem, but a benefit. So just evaluating your patient and thinking about the pathophysiology, trying to gather all the information that you can to try and set them up in these particular phenotypes could help guide management. What about the principles of cardiovascular approach? As I was training in neonatology, we were always taught at that time that one of the possible cardiovascular approach to manage hypoxic respiratory failure is to increase the mean blood pressure. And the idea being, if you increase mean blood pressure by increasing SVR, the PDA shunt will reverse. And historically, I'll be honest with you, this is what when I was a resident or a first year fellow, we oftentimes use dopamine and fluid boluses to try and increase blood pressure. But personally, I didn't see as improvement in oxygenation despite increasing blood pressure. And I think in hindsight, that probably why, because we didn't think about the impact on PVR. The impact on SVR is relatively easier to see because our blood pressures are continuously monitored and we can see the blood pressure going up, but we don't really monitor PVR. And hence, it's sort of, unless you're consciously thinking about it, you might not realize that it's not about SVR going up, it's about PVR and SVR ratio coming down. So you want to raise your SVR in a way that it supersedes PVR. That's the only way the shunt is going to reverse, by changing the resistance across it. So it's important to consider the impact of PVR on of the drugs that we are giving from a cardiovascular system, and among other things. There is some data, animal data, which indicate that dopamine, for example, particularly in hypoxic conditions, actually increases PVR quite a bit, and it may not benefit the PVR-SVR ratio despite increasing the blood pressure. What about norepinephrine, another vasopressor we use often to support circulation? These are pre-post echo data in newborn infants, where people looked at the mean pulmonary artery pressure and its ratio to mean systemic arterial pressure pre and post starting drug. As you can see, and I'm not showing the raw data, but in every patient that they started the norepinephrine, both pulmonary artery pressure and mean arterial pressure went up. But in majority of cases, the systemic arterial pressure went up more and the ratio actually came down. As you can see here, these are all individual patients. So bear in mind, there was an occasional patient where the pressure seems to go up or remain more or less stagnant. So norepinephrine, what we understand right now, will increase your pulmonary artery pressure also, but in a more number of patients, it increases systemic arterial pressure more than pulmonary artery pressure and may reduce the overall ratio. What about vasopressin? Now, that's a drug that you will hear us talk a little bit more about. People from Toronto use it quite a bit. And I think Patrick is from the same coming from the same place. We use vasopressin and PPHN to maintain blood pressure quite a bit. And the reason being that it seems that vasopressin as a drug increases systemic blood pressure exclusively and does not change the pulmonary arterial pressure much, making the change of ratio quite a bit. So these are data from 15 children with pulmonary hypertension who underwent catheterization and were given boluses of 3 different drugs, and their pre and post pulmonary artery pressure were measured. And I'm just highlighting the vasopressin and epinephrine data. And you can see here, the pulmonary artery pressure after vasopressin actually did not increase at all. If anything, in some patients came down a little bit. While epinephrine increased pulmonary artery pressure. Now, bear in mind, this is alpha dose epinephrine, not beta dose. They use a big bolus. It actually increased pulmonary artery pressure quite a bit. And when you look at the ratio, because the systemic pressure also went up, the aortic pressure, in vasopressin, every single case, and there are only 5 patients, I do agree. But despite that, every single case, the ratio of the pulmonary artery pressure to aortic pressure actually went down. Again, providing a little bit more consistent effect. While in the epinephrine case, in some cases it went down, but in 2 cases it actually went up because the pulmonary artery pressure went up too much. And it's very hard for us to predict who is going to have how much increase in pulmonary and systemic pressure from the drug. So which is why in case you want to reverse pulmonary artery shunt, pulmonary to systemic shunt, we tend to go for vasopressin quite a bit, simply because of the predictability of response of pulmonary vessel bed. Having said that, there's not enough data for us to actually strongly recommend it, but I certainly will say that think about the impact on both circulation and not just one when you're using cardiovascular drugs. This is a quick recap of pulmonary vasodilators. I think as clinicians, we all need to be aware of their existence and which pathways they actually target. As you can see here, there are 4 key pathways that we often use in clinical practice. The cyclic GMP pathway, from where the inhaled nitric oxide comes from. Sildenafil is also in the same place. The data for sildenafil is there, but it's not robust enough to actually call it a first line, but it certainly works to reduce pulmonary vascular resistance. The cyclic AMP pathway, you have prostaglandins, prostacyclins, and PDE3 inhibitors like milrinone, which will cause vasodilatation. On the endothelin pathway, we have bosantan, which also promotes vasorelaxation. While on the rho kinase pathway is primarily preclinical, I understand there are some clinical data in adults now, but there's no newborn data to actually use Fasudil, which is the drug that causes vasorelaxation by targeting this pathway. The key message here is that these drugs are there and they're available. The data is limited, but using physiology to your advantage, you can actually use combinations of these drugs to improve your patient's hypoxic respiratory failure. And that's important when you're trying to target the pathophysiology or hemodynamic pathophysiology of these patients. So this is just my take on the various cardiopulmonary agents that are available to us in clinical practice. Sildenafil, for example, it reduces pulmonary vascular resistance, but also reduces systemic vascular resistance. It can be used as an alternate pulmonary vasodilator, especially in settings where INO may not be available, or it could actually help you wean patients who are INO dependent and prevent rebound hypoxemia. Milrinone reduces pulmonary vascular resistance, also reduces systemic vascular resistance, but also is a positive inotropy and actually a lucitropic agent. Basically means it promotes better relaxation of the heart and improved diastolic dysfunction. In terms of indications, we tend to use it in normotensive patients who have high PVR and or evidence of cardiac dysfunction. It is contraindicated if you have hypotension because it's going to make it worse. A caution there that in the presence of therapeutic hypothermia and HIE, we have found that patients tend to become severely hypotensive with milrinone if used without taking precautions. So just keep that in mind. I wouldn't say it's contraindicated, but certainly a caution. Epinephrine at low dose, it's a positive inotropy. It does not cause increase in pulmonary vascular resistance or systemic in low doses. In fact, there's a data saying that it might actually even relax a little bit because of its beta-2 effects. On the other hand, on higher dose, which is the alpha dose, it increases both SVR and PVR quite a bit. So we use low dose epinephrine for cardiac systolic dysfunction and when there is low cardiac output. Norepinephrine is increases SVR more than PVR, as I was showing before, and also has positive inotropic effects. So we use it for associated vasodilatory shock and perhaps for to promote shunt reversal, especially when vasopressin is not a desirable agent. Dobutamine primarily is an inotrope with some peripheral vasodilatory effect because of beta-2. And it primarily is to improve cardiac dysfunction or systolic dysfunction or improve low cardiac output state. It can cause tachycardia in high doses, particularly when you go to about 12.5 to 15 mics. Not always a bad thing because tachycardia does improve your cardiac output. Having said that, it will reduce your filling time. So just keep that in mind. And as I said, for vasopressin, it increases SVR and perhaps does not touch PVR or perhaps even reduce it. So from our point of view, it's actually a quite physiologically appropriate agent when you're trying to do a shunt reversal in a patient when you think the PDA shunt is a major contributor, or to treat hypotension when we don't want to increase PVR by our agent. We tend to use in that particular context quite a bit. So this is how you put them all together from my point of view. For patients in whom the right to left shunt is a major contributor, for example, towards your reduced pulmonary blood flow, the goal is to try and reduce the PVR to SVR ratio, either by using additional pulmonary vasodilator agents if they can be tolerated systemically, or by increasing SVR using drugs like vasopressin or norepinephrine. For patients in whom there is a major systolic and diastolic dysfunction, where that is a major contributor to your hypoxic respiratory failure, then correcting the pump failure first, perhaps is the first approach before we go towards other additional vasodilators. I'm just going to quickly show a couple of cases just to highlight this point more. This is a patient who is say 36, born at 36 weeks with the wrong rupture of membrane history, who was born, was vigorous, but was severely hypoxemic, was handbagged, intubated, INO, as you can see here, muscle relaxed, fluid bolus, bicarb and all of that, but did not respond as blood pressure was actually normal. There was no pre-post ductal saturation difference, and we did a scan at 4 hours of age. And as you can see here, if you can see this slide, at the bottom is the LV and the top is the RV. And I'm sorry, the video is not playing as well. But what you really see here is a severe systolic biventricular dysfunction, both right and left. Right appears to be more than left. We also confirmed pulmonary hypertension physiology and saw the PDA shunt was quite low velocity, but a lot of it was left to right, does not have a high velocity right to left shunt. So from a physiological standpoint, we confirmed the PPHN, we confirmed that it's complicated by low pulmonary blood flow, and it was coming from from pump failure because extremely low right ventricular output. And so from that point of view, our strategy became to try and improve the right ventricular pump function and reduce PVR and avoid any agents that may worsen the PVR. So we essentially started this patient on a low dose epinephrine and then monitored the gas and lactate and markers of perfusion. And you can see what happened here. Once we started on epinephrine and the pump function improved, the right ventricular output improved and the FiO2 kept coming down. And once we reached an FiO2 of 45%, the blood pressure was quite robust. That's when we added milrinone and the patient came under room air and over the next 12 to 14 hours. This is the pre-post ductal saturation difference. We often rely on this marker quite a bit, but this particular patient, despite having severe pulmonary hypertension, had no difference. They were all together all the time. And that's important to note that absence of pre-post ductal saturation difference does not rule out PPHN physiology. Because if you have severe RV dysfunction, you're going to have low cardiac output. And low cardiac output means not enough volume of blood is going to go across the PDA to actually produce that differential saturation that we are looking for. Some patients may actually not have a PDA, they may have a small PDA, or the net flow across the PDA might be balanced. And in those situations, we might not have pre-post ductal saturation difference. So it has a poor ability to rule out. It certainly can rule in the context of HRF, but cannot rule out. Quickly, a second case, again, a 36-week IUGR baby, similar type of history, born, was hypoxemic. This particular child actually did have pre and post saturation difference. The blood pressure was a bit soft, but despite INO, mechanical ventilation was still hypoxic respiratory failure. And so we scanned him at 2 hours of age. Hopefully this will play better. And what you will see here at the bottom is the left ventricle, which actually is contracting quite well, but the right on top is quite dilated and severely dysfunctional. And you can see here the right side is quite big and the left is small. And what we found here was severe RV systolic dysfunction, but a lot of dilatation. The LV was normal function, but small volume, actually being compressed, but the right side having low preload and low filling. And here you can see the PDA shunt had a big right to left component, giving you that pre-post saturation difference, which was largely suprasystem pressures. But the cardiac outputs were not low. And the RVO was within normal range for age, and so was the LVO. So we again confirm PPH in physiology. We confirm that it is complicated by low pulmonary blood flow. And why I say that is because we look at the pulmonary vein Doppler, which was very low, and the LV was low volume, means low preload. That indicated to us that there is relatively less blood going in the lungs, and because less is coming back to the left heart. However, that low pulmonary blood flow, despite having pump failure, was not coming from low RVO. It was coming from PDA shunt, significantly removing the blood from the pulmonary circulation. So we felt that the PDA shunt was a major contributor to low pulmonary blood flow, and pump failure, though present, was not causing pulmonary blood flow low because we're still able to pump enough blood. So in this particular instance, we focused on reversal of PDA shunt with the help of Vasopressin, with the idea that if we can do that, we can put more blood in the lungs and perhaps improve oxygenation and LV filling. So we started this patient on Vasopressin to support his blood pressure, which was already soft, and promote pulmonary blood flow. At the same time, we did give a low dose dopamine to try and improve the RV pump function. And that's what happened. Once we start Vasopressin, over the next few hours, the FiO2 came down to 80%. And once the blood pressure became robust, we added Milleron to the whole picture. And then that has a dramatic effect. In the next few hours, the FiO2 came down to 30 and then 25 and then room air. So it just goes to show that how we tend to use just a physiological sort of concept, why the second case had high RVO despite having severe RV systolic dysfunction. That was because of dilatation. So cardiac dilatation is a adaptive mechanism to afterload, which can, so if you have big ventricle, it doesn't have to contract that much to pump the same amount of volume compared to a non-dilated ventricle. So that's probably why that patient was able to maintain his cardiac output. So I'm going to skip these things, but the key message here is to try and define or try and phenotype your patient. The clinical assessment alone is not going to be enough to be able to pick up all these nuances and understand what is the exact phenotype, which is why you do need a comprehensive echocardiography to try and understand where this patient stands. And the way we tend to do echo and PPH in patients is we first confirm PPHN. And as I was showing by examples, we divide our assessment into right and left heart. And in the right heart, we ask the same question: what is the systolic performance? Is the RVO compromised? Could this be preload related? Could you have pulmonary blood flow low? Is there dilatation? And then we ask the same question in the left heart. And once we try and got all the positive findings, we go back to the clinical problem. Can my positive findings on the echo explain the HRF or hypoperfusion that I am seeing clinically? And can they go together using the algorithm that I was showing before? And if they do, then we try and target those pathways and try and reverse, with the idea that if we can reverse that pathophysiology, we could reverse the HRF as well. So I'm going to stop there at this time point with a summary that you have to remember PPHN is about elevated PVR. It's about impaired myocardial performance. You must remember the problem with the heart function, especially focusing on the right side, which is quite difficult to know clinically because we don't really have any invasive monitoring. We have to consider all contributing factors, use oxygen therapy judicially in avoiding hyperoxia and hypoxemia, and remember the effect of mechanical ventilation on PVR, always avoiding over distension, as we have learned a couple of days back in this course. INO is effective. for hypoxic respiratory failure, but we must have an effective approach for ourselves for iron or non-responders. In my view, at least, the TNE evaluation can really help determine the nature of hemodynamic instability, especially early in disease process. We have to consider cardiotropic support to optimize cardiac output, but avoid agents that may adversely affect the PVR, which we would not know if we are not looking for it. I think we should proactively determine whether the right ventricular output is low, whether pulmonary blood flow is low, and is there RV dysfunction, and what is the contribution of shunt? Is it positive or is it negative? And based on that, we individualize management using the physiology. And if we're not getting desired response, we revisit the pathophysiological understanding that we have for the patient. And in general, my view, if we use these approaches, we often are able to reverse a lot what we are saying and able to stabilize these patients quite early compared to letting them be hypoxic. So with that, I'm going to stop. I think I'm already over time by a few minutes. Thank you all.
Thank you, Dr. Jain. We're going to go ahead to our next speaker, which is Dr. Neil Patel. Neil is a neonatologist in Glasgow with a lot of experience in CDH, and he will talk to us about how to navigate acute pulmonary hypertension and congenital diaphragmatic hernia and what to do in those patients. Neil, take it away. Thank you.
Thanks very much, Adrianne. Thanks for inviting me to join you all today, and to everybody who's listening for joining as well. Really grateful to Amish for that fantastic talk, and many of the principles that he described so beautifully we're going to be applying, but in the setting here of congenital diaphragmatic hernia. So I'm hopeful that you're going to see some consistent messages through a combination of his talk and my own. So congenital diaphragmatic hernia, as you'll know, is due to defect in the developing diaphragm, which can be a variable size and allows abdominal contents to herniate into the fetal chest. And the clinical phenotypes of this condition can be very variable, and that's something that we're going to touch on, but with particular interest in this role of the pulmonary circulation and the heart in contributing to that. What I'd like to talk about today is, first of all, how important pulmonary hypertension is in terms of its relationship with outcomes. So I'm sorry, this is a slightly busy slide, but it's to explain a couple of principles. This was a study from Anita Mungrady and colleagues in West Coast of the United States, where they looked at a cohort of 136 infants with CDH and classified their pulmonary hypertension through the first 6 weeks of life based on predetermined criteria. And if you look down the left-hand side of this table, what you'll see is that from week 1 to week 6, the proportion of patients who were classified as having pulmonary hypertension reduced, and that reflects the natural history of this condition, the fact that all patients start with a degree of pulmonary hypertension, but in the majority it improves over the course of the first few weeks. But what's striking is that if you look from week 2 onwards, the presence of pulmonary hypertension at that stage was associated with adverse outcome. That's death or prolonged intubation, or in survivors, need for oxygen or ongoing respiratory support. And really, the question for us is to say, what are the mechanisms by which pulmonary hypertension, that is elevated pressure in the pulmonary circulation, contribute to adverse outcomes in these patients? And what can we do to understand that in individual patients and perhaps to modify that potential outcome? And to do that in this talk today, what I'd like to do is, first of all, focus on what are the developmental origins of pulmonary hypertension and CDH, what are the mechanisms and the factors that contribute to those from fetal life. And then think about how they contribute to postnatal pathophysiology. And that will be reiterating a lot of the principles that Amish just mentioned as well. And then we'll use a couple of clinical scenarios to talk about the practical application of that, and in particular stressing the assessment of the circulation in these patients and a targeted approach to management. So if we think about the fetal determinants of pulmonary hypertension, circulatory compromise, and CDH, there are really 3 key ones. The first, which many of you will be familiar with, is pulmonary hypoplasia in these patients. If you look at this histological specimen from a CDH patient on the right-hand side, you can see the reduced number of alveoli, which accompany reduced number of airway branches in these patients, and ultimately there's reduced macroscopic and microscopic lung volumes, which contribute to ventilatory failure in postnatal life, but also mean that there's a reduced mass of the vascular bed within these lungs as well. The second significant component of pathophysiology in the fetus in these patients is an abnormality of the pulmonary blood vessels themselves, particularly the pulmonary arterioles. And you see that in this slide here on the left-hand side, pulmonary arteriole in CDH patient, which has a narrow caliber and a thickened wall, thickened medial and adventitial layer in comparison to this control specimen from a patient who died of sudden infant death syndrome. And it's these changes in the pulmonary arterial structure which contribute to both a fixed and a dynamic increase in pulmonary vascular resistance in these vessels. And this is a pre-capillary increase in pulmonary vascular resistance in the pulmonary arterial system. And the third important finding in the development of patients with CDH in the fetal stage is a relative hypoplasia of the left ventricle or the left heart. And it's something that was seen originally on postmortem studies, including in this one by Siebert and colleagues, where they reported reduced mass of the left heart structures in CDH patients compared to controls. But it's been confirmed in a number of fetal ultrasound studies, including this recent one from colleagues at Bambino Gesù Hospital in Rome, where they were able to demonstrate that the nature of this left ventricular hypoplasia is a relative narrowing and elongation of the left ventricle that's certainly observable from mid-gestations up until late gestations. And the mechanisms of left ventricular hypoplasia in these patients may be multiple, actually. Direct mechanical compression from the herniating abdominal contents in the chest may be one, but it's also hypothesized that the reduced pulmonary blood flow in the fetus, combined with perhaps some alteration in ductus venosus flow more towards the fetal right heart, may contribute to the relative hypoplasia of the left ventricle. Now, in the fetal circulation, which is represented on the left-hand picture here, those changes in the developing fetus with CDH, the pulmonary hypoplasia, those abnormalities of the pulmonary arterial system and the left ventricular hypoplasia may not have a significant functional impact on the fetus. Because, of course, it's in that situation, it's the right heart that is supporting the systemic circulation predominantly through ductal flow. It's only at the transition to ex utero life that those developmental abnormalities may actually start to have a real impact on the patient. And if you think about the critical stages of the transition, there's the inflation of the lungs, where lung recruitment and alveolar oxygenation are important in contributing to reduction in pulmonary vascular resistance. And there may be aberrations of that due to the relative hypoplasia of the lungs that we talked about. But there's also failure of the normal decrease in pulmonary vascular resistance because of those structural changes in the pulmonary vasculature that we saw. And those are subacute and chronic changes that are going to persist into postnatal life. And they will that failure of the normal reduction in pulmonary vascular resistance, the failure of the normal increase in pulmonary blood flow in the first moments of life, is going to contribute to reduced left atrial filling, and we're going to see the impact of that when combined with left ventricular hypoplasia. So if we think about that circulation in this baby from those first few minutes and breaths into the next few hours and days, we're going to see an impairment in the circulation due to that increase in pulmonary vascular resistance. As we said, a key contributor to that is the abnormalities of the pulmonary vascular structure. And the consequences of that, as Amish explained, are going to be promotion of right to left shunting at the level of the atria and the duct, but also intrapulmonary shunting. And that will give us the clinical picture of hypoxia in these patients. But that increased pulmonary vascular resistance also exerts an increased afterload on the right ventricle. And as we heard, one of the compensatory mechanisms of the right ventricle, which you see in this apical four-chamber view of the heart, is a dilatation of the ventricle. But there's also an ongoing maladaptive response, which is hypertrophy of the ventricle to try and achieve the pressures required to overcome that increased resistance. And I say it's maladaptive because, as shown in this sort of schematic diagram on the right-hand side here, the ventricle goes from this normal thin-walled crysenteric structure to this thick-walled concentric structure. And as the myocardium hypertrophies, its myocardial oxygen requirements increase, but at the same time, we see a reduced gradient for coronary perfusion. And there's a setup there for right ventricular dysfunction. And if the ventricle starts to fail, that's when we get an uncoupling of the ventricle and the pulmonary circulation, in the sense that the right ventricle is not able to generate sufficient pulmonary blood flow. As Amish also described, when you progress from that coupled dilated state to that uncoupled failing state in the right ventricle. And the right ventricle, of course, will exert some influence on the left ventricle, as you heard in previous talks earlier in the week, through mechanisms of ventricular interdependence, the shared septum, the shared myocardial fibers, the shared pericardial space. If there's right ventricular dysfunction, it's going to affect left ventricular shape and function. But in CDH, and I think it's a fairly unique finding in CDH, there's also this potential for primary left ventricular dysfunction that we think is partly set up by that relative hypoplasia of the left ventricle. And at that transition at birth, when the ventricle is asked to take on that role of supporting the systemic circulation, but at the same time against an increase in afterload as the placenta is removed from the circulation, it's really like the perfect storm for this LV. That's the way I kind of view it. So everything is against it. The right ventricular dysfunction, its pre-existent hypoplasia, plus this acute change in afterload. And in CDH, we certainly recognize that there are a number of patients who have left ventricular dysfunction that is discrepant compared to the degree of dysfunction in the right ventricle. Now, important consideration is that in the setting of left ventricular dysfunction, particularly in diastole, we'll see increased left atrial pressure, increased pulmonary venous pressure, and that in turn will lead to a post-capillary increase in pulmonary vascular resistance. So an important consideration here is that increased pulmonary vascular resistance in CDH may not just be due to those abnormalities of the structure of the pulmonary arterial circulation, but also, or more importantly in some situations, due to the impact of left ventricular dysfunction. And that's important when we think about how we might manage those patients. We'll come back to that. But you can see here how this disruption of the normal circulatory function gives rise to the clinical phenotypes. Biventricular dysfunction will produce reduced cardiac output, reduced systemic blood flow, which will contribute to the picture of systemic hypotension in these patients, but also worsening systemic hypoxemia and metabolic acidosis. And of course, there's a positive feedback loop because hypoxemia and acidosis will worsen our pulmonary vascular resistance and our cardiac dysfunction and contribute to that spiral that you often see happening in front of you of these patients just progressively getting worse. That can be really quite scary to manage. And the importance of cardiac dysfunction as a determinant of outcome and disease severity in CDH is something that we were able to look at quite recently in an analysis of over 1,000 patients in the CDH study group registry. And what we did here was we classified these patients according to their cardiac function on their first echocardiogram in the first 24 hours of life. And here you see a Kaplan-Meier plot demonstrating that over the first 100 days of life, survival was, based on that initial echocardiogram, was greatest in those patients who had normal function and progressively lower in those patients who had right ventricular dysfunction, left ventricular dysfunction, or biventricular dysfunction. And this analysis was able to demonstrate that left ventricular dysfunction is independently associated with adverse outcome in these patients. So again, reiterating that point that it's not just about looking at pulmonary artery pressure and at the pulmonary circulation, but also at cardiac function. So let's bring it back to the clinical situation in our critical care unit. How are we going to apply that knowledge of the developmental abnormalities and their interaction to our management of our patients? Possibly the most important message I hope I could get across in this talk is this idea of these three interconnected components, and they're potential contribution to this clinical picture of pulmonary hypertension in an individual patient. And the message here is really that when you're looking after a patient, to think about what the relative contribution of each of those is to their clinical phenotypes, their pathophysiological phenotype. And that may be an impairment of ventilation, degree of hypoxic shunting, but also degree of right and left ventricular dysfunction. And it's important that in each patient, we have an approach of structured assessment that will allow us to understand what the contribution of each of those relative components of the pathophysiology is at any one point in time and between different patients. So for ventilatory function, as a reflection of the impact of pulmonary hypoplasia, we want to look at how much ventilation we're requiring, what our CO2 clearance is like. In terms of assessing the pulmonary artery pressure, we want to do that by echocardiographic means, but also by looking at pre-post-ductal saturations, accepting the limitations that Amish just mentioned. And we also want to look at oxygenation as an indicator of the degree of hypoxic shunting. And it's important that we also use functional echocardiography to help us understand the cardiac morphology and the function, and to also incorporate measures of systemic oxygen delivery. And hopefully by doing so, we'll then be able to make a more targeted and informed decision about how best to manage this patient. And the therapeutic principles that we should follow, depending on the individual pathophysiology, of course, are to optimize ventilation, but avoid barotrauma and void trauma in these fragile lungs. And of course, the concept of gentle ventilation in CDH is now very well established, accepting a degree of hypercarbia and permissive respiratory acidosis. We also want to minimize the pulmonary vascular resistance, and we'll come on to how we can do that. I'll illustrate that with a couple of cases. And we also want to optimize cardiac function and systemic blood flow. And it's important to understand that as we target our therapy towards each of those different areas, we may have an impact on the others, both in a positive and a negative way. So let's look at some cases, hopefully to illustrate some of these concepts. This is a patient with an antenatally diagnosed left-sided congenital diaphragmatic hernia. The observed to expected lung-head ratio, which you may well have heard about, this is a measure of lung volume normalized to head size, which is a fairly standardized approach to prognostication in the fetus and CDH. And the ratio was 32% in this patient, which sounds quite low, but actually puts them in a moderate group in terms of prognosis. And the patient had delivery induced at 38 weeks gestation, and at 6 hours of age was in around 70% oxygen, with a degree of hypoxia, you can see there. Degree of hypercapnia, and just borderline lactate. And when we look at the echocardiogram, here showing the ductus on the left-hand side, you can see a really big duct here with bidirectional shunting, which is shown on the Doppler, and really indicating to us that this patient has pulmonary artery pressure that is around the same level of the systemic pressure at that point. The other thing that can give us a little bit of an indication about the nature of the RV afterload is looking at the pulmonary artery Doppler in this patient. And what you see here in the pulmonary artery waveform is quite a steep upslope or acceleration. And then on the downslope, this kind of notched appearance, both of which are indicators of increased pulmonary vascular resistance. And indeed, you can use this measure of time to peak velocity or acceleration time. It's the time from the onset to the peak velocity in the Doppler, normalized for the RV ejection time, to give some quantification of that relative pulmonary vascular resistance. And this particular study by Florian Kipfmuller and colleagues, they were able to show that a ratio of less than 0.29 was predictive of adverse outcome in CDH patients. But what about the cardiac function in this patient? Well, if we look at this apical four-chamber view, we see a dilated right ventricle, septal flattening, all consistent with the right ventricular response to that increased afterload. Left ventricular function, even just eyeballing it here, actually looks pretty good. So if we think about this patient's, if we think about this patient's right ventricular function, one of the other ways that we can try and assess and quantify it is using this technique of tissue Doppler imaging. Here we use Doppler not to look at the velocity of blood flow, but to look at the velocity of the myocardium, typically in the basal region, in this longitudinal plane. And this is a normal waveform in a control infant. You see a systolic velocity, S prime, which we can measure as a measure of systolic function, and then two diastolic velocities, E prime in early diastole, A prime in later diastole. And in this patient with right ventricular dysfunction in CDH, we see a reduction in the S prime velocity indicating systolic dysfunction, but also in this particular case, a complete absence of that early diastolic velocity, consistent with early diastolic dysfunction in the right ventricle. And that's something we characteristically see in CDH and other pulmonary hypertension states. So in this particular patient, we're seeing preservation of left ventricular function, but this phenotype of right ventricular dysfunction and hypoxia. So it makes sense that in this setting, our approach should be targeted reduction in pulmonary vascular resistance to try and improve oxygenation and right ventricular function. And of course, we should make sure that we're doing the basics well first, optimize sedation, optimize lung recruitment, and thereafter maybe start to think about use of pulmonary vasodilators. I'm not going to go into individual agents because I know you're hearing about those in other talks. So another consideration is also, as Amish mentioned, to think about the role of the ductus in this situation. And in CDH, we would tend to think about keeping the duct open with prostaglandin if it's closing and in a setting where the pulmonary artery pressure is elevated around systemic and we're seeing right ventricular dilatation, but also importantly, dysfunction. And in that setting, we're trying to use the ductus to reduce the effective afterload on the right ventricle and improve its performance. In many cases, the duct is actually widely patent already. And because we're doing regular functional echocardiography, we can just track that and make sure that it's continuing to remain open when we want it to, and only use the prostaglandin if it actually looks like it's closing in the setting of ongoing right ventricular dysfunction. Let's think about another case now. A similar kind of story, like left-sided CDH, antenatally diagnosed. This time, when the lung volumes were assessed in the fetus, the lung head ratio was 24%. So that moves this patient more into the severe category based on lung volumes. At 8 hours of age, patient has hypoxemic respiratory failure with high FiO2, but low preductal and postductal saturations, borderline blood pressure, and metabolic acidosis. As in the previous patient, when we look at the duct, we can see a widely patent duct. In this case, although it's bidirectional on the Doppler, it's predominantly right to left, indicating to us that in this case, the pulmonary artery pressure is probably just in excess of the systemic blood pressure. What about cardiac function in this patient? Well, here you can see the right ventricle isn't particularly dilated, but probably a degree of right ventricular dysfunction, even just on this qualitative assessment. The septum's moving quite well, but I would argue that the left ventricular free wall is probably not moving quite as well as we might hope, even just in this 4-chamber assessment. And one of the techniques that we've used to try and look more quantitatively and objectively at left ventricular function in CDH is speckle tracking echocardiography, which allows us to look at the regional strain or the relative shortening and lengthening of regions of the myocardium. And you can do that to look at multiple planes, but also at individual regions within the free wall and the septum and the ventricle. I won't go into too much detail in the interest of time, but this patient had a global longitudinal strain in this view of -9. Normal would be around -20, -22, so indicating quantitatively some significant impairment of left ventricular function. So this patient has a slightly different phenotype from the previous one. We're seeing here significant left ventricular dysfunction, which was contributing to that systemic hypotension, alongside a degree of right ventricular dysfunction as well. And in this situation, our aim should be to support cardiac function, including specifically in that left ventricle. And we would do that using positive inotropes, but also trying to optimize the systemic vascular resistance. And by that, I mean avoiding excessively increasing the afterload in this left ventricle. So we would avoid excessive vasoconstriction. And a little bit like the case that Amish showed you, our approach here was lower dose epinephrine, and then once the blood pressure had stabilized, the addition of milrinone. Now, by treating the cardiac dysfunction in the left ventricle here, we hope that that will improve pulmonary vascular resistance because it's going to reduce that post-capillary component of the elevated pulmonary vascular resistance. I've said here that in this situation, we're going to be cautious with pulmonary vasodilators. And the reason for that in left ventricular dysfunction is because of this theory that if we excessively pulmonary vasodilate, we may risk increasing pulmonary venous return to the left atrium. And if the left ventricle is failing and has left ventricle is failing, already has diastolic dysfunction, we may potentially exacerbate that. We don't have much objective evidence that I can show you of that, and it's theoretical, but I think it's very reasonable in these patients to be cautious about pulmonary vasodilator therapy. Just one other consideration in treating left ventricular dysfunction in this setting is we tend to avoid drugs that will be positive chronotropes, and particularly that means dopamine and dobutamine at higher doses, because of course, if they drive up the heart rate, they'll shorten diastole and worsen diastolic function and filling. And as I mentioned, we'll avoid excessive vasoconstriction, which may increase afterload on that failing LV. So here's some serial echocardiograms in that same patient to show you our management approach and the response. We started low-dose epinephrine on day 1, and as the blood pressure improved, added in milrinone. We tend to use it in this setting without a loading dose, just to avoid that risk of hypotension that Amish mentioned. We see an improvement in the left ventricular global longitudinal strain within the first 3 days in response to that. And in view of this ongoing ongoing right ventricular dysfunction and hypoxemia in this patient, we then started to add in intravenous sildenafil once the left ventricular function was improving. Okay, just very briefly in the last minute or two, one final case. Another patient with an antenatally diagnosed left CDH, observed to expected lung head ratio 36%, putting them again in the moderate group. But at 10 hours of age, this patient is actually pretty unwell. They've got hypoxic respiratory failure and 100% oxygen. They're clearing CO2, however. We're managing to achieve a CO2 of 8. They're hypotensive and significant metabolic acidosis. So let's have a look at their cardiac function. And a little bit like the last patient that I showed you here, we've got left ventricular dysfunction, but as you can see from the apical 4 chamber and short axis views here, this is severe left ventricular dysfunction. That ventricle is hardly moving. The global strain is measuring at -6%, very low. Even looking at the 2D loops, you might even have expected it to be lower than that. And in this particular patient, in the first 24 hours, despite medical management, similar to the last patient, they just had worsening hypoxic respiratory failure and profound hypotension, and progressed onto ventricular arterial ECMO at 24 hours of age. Now, what's striking is that when we look at the echocardiogram on day 3 of life on ECMO, you see that left ventricular function has already improved significantly, and we've been able to start weaning the epinephrine that had been started pre-ECMO, and indeed start to wean ECMO support. By day 4, because LV function had improved dramatically, we were able to decannulate from ECMO. We were only on moderate conventional ventilation after that, and this patient progressed quite quickly to repair on day 6 of life. And what this patient illustrates, I think, is firstly how profound and severe left ventricular dysfunction can be in these patients, but also how it can be quite discrepant from the degree of respiratory compromise and right ventricular dysfunction. It also highlights that left ventricular dysfunction in these patients is a transient phenomenon. Even though it's very severe, it can improve quite quickly, in this case, with the addition of mechanical support on ECMO. And it also allows us to see how serial functional echocardiography allowed us to have a much more informed approach to timing of surgery in this patient and timing of weaning of ECMO support. The other point that it highlights is that in the medical management of this patient early on, if we had aggressively vasoconstricted with a vasopressor, then we would almost certainly just have exacerbated that degree of severe LV dysfunction. The other point that case makes really is how we can use this phenotype of pulmonary hypertension and cardiac dysfunction CDH to help guide ECMO strategy, and and really interested to hear a little bit more about that later in this session. But I would argue that that case illustrates how, where we see a patient with disproportionate left ventricular dysfunction, we can hopefully reverse or help to restore function quite quickly with a short course of ECMO, wean them off, and then repair them thereafter. In those patients where we have a phenotype which involves more severe pulmonary hypertension with oxygenation failure and right ventricular failure, or where we have hypercarbic ventilation failure, then I think the ECMO strategy there should be more towards one of early repair to try and optimize lung volume, optimize ventilatory function, hopefully support improvements in pulmonary hypertension, and wean off after surgical repair. Just very briefly to close, I want to mention two potential areas that may impact on how we manage these patients and also their cardiovascular phenotypes in the future. The first is fetal tracheal occlusion. The very recent publication of the Total trial has shown an improvement in survival for patients who have a tracheal plug inserted in fetal life. And the secondary outcomes in that study suggested some improvement in cardiovascular pulmonary hypertension parameters as well. Of course, one of the adverse associated effects is preterm labor. And also, on a practical level, this involves quite a substantial disruption of the normal pregnancy period for patients who undertake the procedure. Second thing is the role of physiological-based approach to cord clamping, where we recruit the lungs before clamping the cord, and early human and animal studies have suggested some improvement in hemodynamics, including pulmonary blood flow in CDH patients. And we await the results of two ongoing trials here in Europe on the potential impact on outcomes in these patients as well. So thanks very much, everyone, for listening. And just to remind you that the key message here is remember the developmental components of CDH and their relative contributions to pulmonary hypertension in postnatal life. There's a variable pathophysiology here, and that's why structured assessment, including functional echocardiography, are key in the management of these patients because they'll help us to make informed, targeted, and individualized management decisions. Thanks very much for listening, and looking forward to your questions, and invite you all to join us at the CDH International Symposium next year. Thank you.
Thank you, Neil. That was wonderful and extremely informative, and really sets up our next speaker, who's going to be talking about pathways for drugs for these very challenging infants and neonates. Speaker requires no introduction, probably the professor of professors, but more importantly, has become a really good friend and colleague over the years. My pleasure to have Steve Abman share some words with us. Steve, all yours. Oop, you are muted, Steve.
I'm unmuted here. Thank you so much, Phil, and Patrick and Amish and everybody. This is fantastic series of presentations and talks, and really I've learned a lot already from this morning's presentations. You know, I'd like to say that so many of the themes were so well presented in the setting of acute pulmonary hypertension, acute cardiopulmonary disease with PPHN and diaphragmatic hernia. What I'd like to do now is translate this over to very similar principles as we apply them to infants who develop chronic lung disease or chronic pulmonary hypertension in the setting of BPD in particular. And so what I'd like to do first is to do my disclosures. I have some grant funding from Shire United Actilion for laboratory stuff. I'm on some DSMBs and advisory boards. None of this really conflicts with my presentation today. My overall objectives today, though, is to first provide a brief overview of the signaling pathways involved in the pathogenesis of pulmonary hypertension. And it's really all the excitement around vascular biology and basic science research that led to the development of current pulmonary hypertension specific drug therapies. And so I'll very briefly go through these, and Amish did a beautiful job giving that overview, and talk about what drugs are available briefly and the pathways and some of the implications, especially in the sense of a bronchopulmonary dysplasia. I also want to highlight that there's a pulmonary hypertension and how we think about it and management is purely related to the context in which pulmonary hypertension is diagnosed in premature newborns, or we call them pulmonary vascular phenotypes of prematurity. And so how we think about things in terms of our strategies and management and the role of drug therapies are all contingent upon what our goals are and why, and what stage of disease are they at. And I'll talk about that a bit more in my presentation as well. And then finally, as everyone's highlighted, and we've struggled with over the past 30 years, the ideas of the three spheres, heart, lung, and vascular, as being so important, not simply in the setting of acute pulmonary hypertension, but I'll make the case that as we think about infants with severe PH and bronchopulmonary dysplasia, that it's these interactions that really drive successful management, even beyond the ideas of which drug therapy to use. And really over the decades, we've learned a lot of severe PPHN in the term newborn. And here's a baby who's on ECMO, high frequency. There's indeed a tank of nitric oxide in the back. And we've learned a lot of lessons about mechanisms, who responds and who doesn't. When you have a non-responder, is it because the primary pathophysiology is not well gleaned? And that's where what you're doing with the echocardiography lessons and courses and the impact that's having worldwide has had on improving management of these kids. But also in terms of heart-lung interactions, cardiac dysfunction, and many things, we learned a lot from the term newborns. And likewise, we've learned a lot of PPHN in the preterm. And way back when, the mythology was that premature babies could not have PPHN because they didn't have enough smooth muscle around their vessels. And lo and behold, we've learned that that is simply not the case. In fact, PPHN is probably more readily present and significantly contributing to those with severe disease than we ever imagined. And it's correlated with the severity of prematurity itself. And then finally, the babies that I'll be talking about mostly in my talk today is really an established BPD, pulmonary hypertension in former preterm infants who have sustained lung disease and often have more severe pulmonary hypertension as well. And so three different scenarios, and yet many of the principles overlap and have a lot of similarities. So I'd like to start by taking a step back and thinking about the components of pulmonary vascular disease most broadly. And this could be said about PPHN babies or CDH or heart disease related to PH. But in terms of BPD, it really starts with the idea of tone and reactivity, that is vasoconstriction, or abnormal vasoreactivity, meaning that for a little whiff of hypoxia, these vessels squeeze like crazy. Abnormal, and that itself is part of the process of failed transition in the first hours of life. It's not simply acute alveolar hypoxia driving this, but rather PPHN as a disease with its full-blown severity in terms of cardiac performance and systemic oxygen delivery deficits and things like that. There's something abnormal about the vasculature, really from the early stages of birth that we've learned about from animal models and explored. And these related to things like nitric oxide and prostacyclin, endogenous endothelial products that mediate vasodilation, excessive production of endothelin, normal in the fetus. It helps maintain high PVR before birth, but when sustained or increased and upregulated after birth, it creates the clinical problems. Then other biophysical properties of the vessels, a little stretch-induced constriction, again, normal in the fetus, excessive in the fetus at risk for PPHN, but persisting in many forms of pulmonary hypertension, even in older children and adults. And so certainly tone and reactivity and remodeling. You saw some examples from Neil about the structural remodeling in CDH very early on that's contributing to some of the refractory or difficult stages of pulmonary hypertension that aren't as responsive to our interventions. And then finally, growth, vasculogenesis and angiogenesis, essential not just for CDH, but also for the premature infant. And that is disruption with early growth of the lung circulation and its ability to develop new vasculature along with the distal saccules and air spaces really leads to this high risk for high pulmonary vascular resistance and pulmonary hypertension. And then finally, the other piece that I would love to talk about more is the idea that angiocrine signaling, that as the vessels grow, so does the distal airspace. And it's this angiocrine signaling, that is the vessels themselves, not because of reactivity or structure per se, but for dysfunction and how they communicate with the airspace, sustains this impaired vascular growth that leads to long-lived abnormalities, higher risk for late pulmonary hypertension and more severe BPD, but also may play a role in some of the sustained echocardiographic and other abnormalities that's being found more and more in older children and young adults. And perhaps the impact of preventing this impaired angiogenesis can be that we could also enhance alveolarization and regenerate the lung. Well, my first task really is related to the physiologic mechanisms of pH, and we already heard from Amish early on about the three different products that are mostly involved with the pathophysiology of disease. And the first on your left you see is endothelin-1 produced by the endothelial cells. It could bind to the subjacent smooth muscle cell through the A and the B receptor, causing vasoconstriction and vascular smooth muscle cell proliferation. And I say this because we tend to think of each of these agents as dilators. We add dilator therapy, which is true. That's the biggest part of what they do functionally. But we also sustain them in the setting where we have a vascular bed, where maybe we don't see reversibility with acute vasodilation. So from the experience from adults and children with different forms of pulmonary hypertension, even in the chronic setting where you don't see an acute response, as you gauge at the bedside with a sick baby with PPHN or CDH abruptly, we often chronically still give these agents for a couple of reasons. We may still blunt reactivity, but we also know experimentally these agents, blocking endothelin or given the N-prostacyclin-derived products I'll speak of, actually stimulate a healthier endothelium, stimulate angiogenesis, and a healthier endothelium will help modulate smooth muscle cell proliferation, perhaps vascular fibrosis. So it's sort of a different sort of way of thinking of why we're using these drugs in the chronic setting, beyond simply do they acutely drop their FiO2 requirement, improve their saturations, and have better blood pressures. And so this is where there's a little bit of overlap, but we still refer to our current agents as pH dilator therapies. And certainly for the endothelin receptor antagonist, that includes bosentan, the one we have most experience with, ambrisentan, a longer acting agent, which we use a lot in the ambulatory setting, especially for older infants and children. And then finally, macitentan is beginning to be used with a little bit more selectivity for the A receptor. Now we know about inhaled nitric oxide stimulating cyclic GMP, and that's led to all the work with inhaled NO as an acute vasodilator. It's especially helpful when you simply add it to a ventilator. Sildenafil, we have the most experience of any of these agents. We have no evidence that starting sildenafil over bosentan, for example, makes any difference, but in selected cases, either adding these together or perhaps someone who's not responsive to sildenafil will actually respond better to bosentan. But we still don't have the biomarkers, the clinical physiology. We're still not sure up front which one to start with. And so this is something that still needs to be explored. Tadalafil is a chronic long-acting PDE5 inhibitor like sildenafil. We use a lot in the older infants and children. And riociguat, we have experience in adults, limited experience in older children, but it's so exciting in experimental models because riociguat as a soluble guanylate cyclase activator and stimulator can target soluble guanylate cyclase. And that's a target for inhaled nitric oxide. What's neat about this drug is that it works when the SGC, the soluble guanylate cyclase, is not very responsive to NO or requires high doses of NO. And it's because if you oxidize SGC, that's when the riociguat and the SGC activators and stimulators just ignore the fact that the SGC ain't great and it still does its thing generating GMP. So I think it's a very exciting novel target, beginning to explore it as an inhalational therapy, again in adults first and beginning some pediatric work. But hopefully someday this will work its way down into the NICU and it may help us in some of our selected cases. And then finally, the prostacyclin pathway. Prostacyclin is generated by the endothelium, works largely through stimulation of cyclic AMP. There are many different agents now that are available. And it's also true that milrinone can act through the cyclic AMP pathway as well. And so if we think about the prostanoids systemically, we're starting to use more and more treprostinil as remodulin. The old days, it was Flolan epoprostenol. And frankly, remodulin's met with more favorable effects because we think it has a longer half-life. We tend to use it in the outpatient setting for those with severe disease who need chronic systemic infusions. So Remodulin ends up being an agent that we now prefer over Flolan. This transition has occurred over time. And we also have inhaled agents, and we have oral agents that are now becoming more and more available. And again, mostly in the ambulatory setting with older children, not yet ready for prime time yet in the NICU. And so these are the agents that I think about in terms of the signaling pathways. What do we know about their efficacy? Well, very, very rare multi-center randomized clinical trials in children with any form of pH at any age. But if one looks in the era before these pH-targeted therapies were available, and this is plots from mostly group 1 disease, that's congenital heart disease associated pH. You could see terrible survival in those blue curves, those blue lines that you see there. 30% survival overall from these historic papers. If one looks at subgroups over time, there was a pretty remarkable increase in survival to 50 to 90%. Again, group 1 patients, chronic pH. But it still suggests that we've made good headway with where we're going with these agents, and yet they're not sufficient. Again, their predominant properties are dilation, and we talk about the ex-primi with BPD, the ex-CDH patient who still has pH. We're really concerned of how could we enhance lung vascular growth and minimize remodeling over time. And so it'd be nice to have more targeted therapies that involve growth factors or pro-angiogenic stimuli. And here's where all the excitement of the potential of early stem cell therapies and other things for the vasculature may enhance or reduce the risk for developing pulmonary hypertension. Well, over time, when we think about the whole group of pulmonary hypertension in children, we found that group 3 disease, that is lung-related pulmonary hypertension, is present in nearly half of our population from about 8 different pH centers throughout North America. And I say this because this has been under the radar for so long. Pharmaceuticals have been more interested in other forms of pulmonary hypertension. It's been largely ignored by our cardiologists, and yet that's a big piece of the pie. And at least in this network, the way we cast the net for getting patients, about half of that group 3 was BPD, about a third CDH, and then some other forms of developmental lung disease made up most of the rest. But still, we know the signal's even bigger with BPD. It's just that these are BPD patients who are enrolled into a prospective registry. So it's a huge signal, a big public health problem. So let me get back to prematurity and BPD itself. We already heard very nicely that the phenotypes make a difference. And as we think about pulmonary vascular disease and prematurity, we'd like to break it out in terms of early pathophysiology, early treatment goals in the first weeks of life. What happens later, weeks to months later, with evolving or established BPD, and then chronic, meaning months to years, or pulmonary vascular disease across the lifespan. And certainly, as we mentioned, PPHN, we heard a lovely talk about it. Again, premature infants are at risk for PPHN. They can have striking responses to nitric oxide, but not every preterm infant who's doing badly on a ventilator should be getting nitric oxide, and we'll hear more about that in a minute. A lot of babies with more extreme prematurity have a delayed transition, where they have a little bit of a roller coaster ride, or their PA pressure is not quite dropping to lower than subsystemic levels, and yet not sufficient to be contributing, let's say, to profound hypoxic respiratory failure. So sort of a different kind of baby in that window. And then finally, the idea that early biomarkers, for example, echocardiograms or NT-proBNP, there's been a lot of research in these areas that target pulmonary vascular disease early, are strongly associated with late risk for developing not just late pulmonary hypertension or BPD, but also poor respiratory outcomes in childhood, more asthma exacerbations, more need for hospitalizations. But the group I'd like to focus on for this talk is really this middle ground group of the weeks or months, babies who have sustained high levels of respiratory support, often with recurrent cyanotic episodes, those who even after NICU discharge can have persistent respiratory problems, persistent pulmonary hypertension, and what to do with those chronic kids. The final category of the chronic, the PVD across the lifespan, I know a number of you, especially Phil Levy, have done a beautiful job in showing that by echocardiogram, these kids aren't off the schneid. They still have some elevation suggested by some echometrics of perhaps having ongoing pulmonary vascular disease, even without overt pH. And it may be that this subgroup is at risk for adult onset pulmonary hypertension, or the cardiac dysfunction that's been discovered and reported on extensively, and other things. And so there are really at least 3 different phenotypes overall that are broken down, each one requiring a different thinking about what's the context of the disease, therefore what's my therapeutic strategy. And the idea of fatal BPD-related pulmonary hypertension has existed since Northway first described cor pulmonale and BPD. All of his cases who died had striking cardiomegaly and right ventricular hypertrophy. And we know that it's still associated with poor survival. This is actually from quite a while ago now, where Mary Mullen's group from Boston Children's showed that late pulmonary hypertension was strongly associated with poor survival. And as we'll talk about a bit later, it's really this early window we're still challenged by. What you all are doing in the NICU matters. How can we improve early survival in this window of time is vital, and we'll talk more about that. We know that pH is related to severity of BPD, whereas if you look at 3 prospective studies, 29 to 58% of these babies had echocardiographic signs of pH. So I think certainly severe BPD co-travels with pH, and yet one has to ask a couple questions. Why don't all of them have bad pH if it's a one-to-one relationship with BPD severity? There's something else about the vascular injury above and beyond what's happening in the lungs themselves. We need to figure it out, but at least it's a way of targeting a high-risk population. And if you heard from the previous speakers, here's our 3 spheres of how we think about pulmonary hypertension and BPD. We go with lung disease, heart disease, and pulmonary vascular disease. All can contribute to high pulmonary artery pressure. And so how we manage the respiratory component is such an important first step, and not overlooking the roles, as we've heard before, of impaired left ventricular function or performance, the presence of LV diastolic dysfunction, persistent shunts across the atria, or a PDA, or perhaps a ventricular septal defect. And then finally, the vascular disease itself. And here's where we start to think about some of the pH-targeted drugs to be applied. So in terms of phenotyping, of course, it begins with understanding the pathophysiology. Central airways disease, especially tracheomalacia, small airways disease, smaller vessels can act asthma-like, and yet they're not asthma, because they have mucus gland hyperplasia. They make a whole lot more mucus than another lung would normally do. There's more edema. There's dysfunction of mucociliary clearance. And the airways themselves have some smooth muscle proliferation. And so some of these babies have hyperreactivity of the airways. And so targeting how to best manage central airways, small airways, and then finally the distal airspace. And that's where I include the decreased lung and alveolar growth, the role of pulmonary edema, and other things. 3 different compartments for us to target as we think about how to first begin to take apart what to do about their pulmonary hypertension, is highlighted there. The other piece is hypoxia. And we're learning now that even intermittent hypoxia early on is a risk factor for developing BPD. We know that targeting slightly higher saturations, avoiding saturations in the upper 80s even, may help us slow the risk for developing pulmonary hypertension. And we've known for quite a while, if you have established BPD, just a whiff of hypoxia is enough to cause quite a striking swing in your pulmonary artery pressure. And these are really old data from a handful of kids, but this principle still holds. That as we look at the left panel, you can see that the pulmonary artery pressure with high oxygen in the cath lab was modestly elevated. But if you make them briefly hypoxic, there was dramatic increases in their pulmonary artery pressure. And likewise, it doesn't take a whole lot of desaturation to cause that. We had some babies whose saturations were just in the upper 80s. You can see how dramatically hyperreactive they are. And one would not see this, does not see that in infants who undergo cardiac cath or exposed to hypoxia with other kinds of diseases. So it's reason why we have to target oxygen saturations, worry about the management and the pathogenesis, but as well as the therapy. How about lung volume? And we've heard before the idea that if you're atelectatic, where you have low lung volumes, as shown here, you have high PVR. FRC means functional residual capacity. We don't directly measure it, but certainly we gauge it radiographically and by changing the ventilator. You hit that sweet spot to drop PVR. And then excessive hyperinflation, of course, you have this, again, rise in pulmonary vascular resistance. And so the challenge is, what do you do with a BPD lung that looks something like this? Heterogeneous lung disease, areas of hyperinflation with atelectasis. So the idea isn't just how to get the most gas into the lung safely, but how to most effectively distribute the gas to avoid the secondary effects on the lung circulation, as well as to improve blood flow and matching of ventilation and perfusion. And this is really the challenge of those infants with most severe BPD. So the way we think about it is this: if you take a gentle ventilation strategy or a traditional approach to an infant who has severe RDS acutely, we tend to use low tidal volume, short I times, and rapid rates. And in those kinds of babies, that may be sufficient, but if you take a lung that's heterogeneous, and it's highlighted here by showing you different time constant regions, where you have high or low resistance, high or low compliance, you will find that most of the gas will go to the highly compliant, lower resistant part of the lung, but not the other regions. This leads to progressive atelectasis, worse dead space ventilation, higher PCO2s, a higher FiO2 need, and many other problems that we see. But take the same lung and give a higher tidal volume with a longer inspiratory time for better gas distribution and slow the rate, we could distribute gas more effectively. The marker should be improved oxygenation, but in some babies, this will also improve their pulmonary hypertension, even short of throwing in pH-targeted drug therapies. And so I think it's important to think about. And here's a simple example: a baby, low tidal volume, high PEEP, respiratory rate about 36, but now this baby's about 4 or 5 months old, still on a ventilator. That rate of 36 just can't get off the 100% oxygen, starting to show spells, has regional atelectasis developing. And simply by changing the few parameters, allowing the lung to empty more to tolerate the PEEP, doing a little bit more with lung clearance, simple things on the ventilator, you could see the FiO2 rapidly drop to 65%, better gas exchange distribution, less hypoxia, hopefully less pulmonary hypertension as well. And so how we ventilate these babies makes a difference. Certainly, this is looking at data from a single center before and after instituting these strategies. We saw a marked improvement in survival in this kind of baby. So what to do when we have echocardiographic evidence of pulmonary hypertension? And our network made some recommendations about checking babies anytime they have severe respiratory disease or signs or symptoms of pulmonary hypertension with BPD at any stage, and we talk about that quite a bit. But certainly even at 36 weeks in those who have more modest forms of BPD or no BPD, we think that performing an echocardiogram will be high yield, and that we could then gauge this according to being absent or mild to moderate or severe, make some decisions on targeting respiratory management predominantly, and then perhaps initiating therapy. And there's a role for cardiac catheterization that's mixed in here that I'll talk about very briefly. And so the role of cardiac cath itself is to assess the severity of pulmonary hypertension, to search for anatomic heart disease and shunt lesions, structural vascular abnormalities, especially pulmonary vein stenosis, to really confirm the presence or absence of LV diastolic dysfunction by looking at wedge pressures directly. Perhaps there are catheter-based interventions that could be done, and in selected cases, thinking about acute vasoreactivity testing to help us select chronic therapies. So this is an example of work that was just published from UCSF, where I thought they did a really nice approach, where here they used echocardiographic markers, and in this case, very qualitative metric of septal flattening, which I know is used very readily at many centers around the country, the world, to assess severity or likelihood of pulmonary hypertension. And they used that with other metrics that included the presence of TR jet velocity, or assessing VSD or PDA systolic flow velocities, and again, using septal flattening. And I can't go through this in detail, but their questions were in the small number of babies of how close was cardiac catheterization with giving us an assessment of pulmonary vascular resistance based on selecting these babies for further study. And it's so interesting to me because it highlighted that the correlates were pretty good, that there was a positive correlation in many of these kids. But the piece I really wanted to show you is they really bring out why we think about cardiac cath in this group. Most of these babies, we start with empiric therapy. They're too small, the risk might be too high. to do caths, especially early in the course. But it's really in the setting where we really want to gauge what's the relative role of high flow from an ongoing PDA or shunt. Or is there evidence of left heart diastolic dysfunction because we see edema whenever we initiate a pulmonary vasodilator? Or if it's late enough in the course, we're seeing edema, is it left heart or is there early pulmonary vein stenosis? And so that's where sometimes, going to the cath lab can be very helpful. And let me just give you a couple examples. This is a baby with LV diastolic dysfunction, was discharged from the NICU, came right back with a viral infection very shortly after discharge, was on a ventilator, on multiple pH agents, but especially when at the start on nitric oxide, you could see how wet the chest x-ray got. And certainly in the cath lab, this child had elevated pulmonary capillary wedge pressures. This child then was started on some milrinone, had unloading of the LV, followed by an ACE inhibitor. And we took away some of his pH drugs to help better manage, not just his pH, but his respiratory failure. Pulmonary vein stenosis, we're seeing more and more. And again, these babies can have serial echoes that appear normal. In fact, in this study from UCSF in Alberta, this is from Emory in particular, showing the high mortality, but a study from UCSF in Alberta characterizing these kids showed that on average, the babies had 4 or 5 normal echocardiograms before they started to see signs by echocardiogram of pulmonary vein stenosis. So, and it usually comes around 36 to 40 weeks. It can be tough to treat, but knowing early, with early mechanical interventions, with stents and dilation, still trying to figure out what the role of pharmacologic intervention should be, but knowing pulmonary vein stenosis, being alert to it and attentive and intervening is vital for improving outcomes. And at least in a series from Spain from several years ago, Maria del Cerro showed that these associated lesions, such as a persistent shunt contributing to the pH, or pulmonary vein stenosis in 27%, or LV end diastolic pressures that were elevated in more than half, that taking these selected subgroups of kids to the cath lab who were worrisome to figure out their physiology more precisely because of failed responsiveness to pH drugs or edema with therapy or other adverse effects can yield and help define the care in selected numbers. And finally, we looked at something additional in the cath lab, and that is acute vasoreactivity testing, where we acutely gave nitric oxide to infants who were in the cath lab for the reasons I just mentioned, test the reactivity. And those who had the most striking response to acute vasodilation at this late stage were those who had better outcomes, meaning time to death or the need for subsequent trach and vent support. And I say this because it wasn't the absolute level of pulmonary artery pressure or the measurement of pulmonary vascular resistance index that was associated. It was this reactivity. So it takes me back to what's reactivity, what's remodeling, what's hypoplasia, how do we learn from that? I still think that we need to learn more about it. But it does speak to the fact that if we can maintain a healthier vasculature, give vasodilator therapies chronically, perhaps there is an impact, at least on a subgroup, that we could expect to see. Number of drugs, we've talked about these pathways already. Evidence for therapy, certainly inhaled, I know an established BPD can acutely improve gas exchange, lower pulmonary pressure in the cath lab as shown in these early reports. And so we still use it on stable babies in the NICU for having pH spells, acute exacerbations with established disease. We use sildenafil quite a bit, and this is an early study of chronic therapies in the ambulatory setting. And I show this because these are babies who were so nervous in the past of starting this agent in former preemies that all of these kids initially required a right heart catheterization before entry into study. A more recent series that I've been seeing, most of the babies do not get right heart caths. We no longer do, because we found that for the most part, there are some kids who have selective adverse effects, but they're relatively rare and seem to be safe and at least is associated with progressive improvements in estimated pulmonary artery pressure. Remodulin as a subcutaneous chronic infusion is something that's becoming more and more, is being used with greater frequency. And there are a few reports now where with more severe, higher levels of pulmonary hypertension, one can manage these babies successfully in the NICU and at discharge, as we do with many of our other forms of pulmonary hypertension. But defining which babies need it and when is still an open story that we really can't answer. But the major recommendation is really we still need multidisciplinary teams. It takes a village, neonatologists, pulmonologists, cardiologists, and others should all be involved in the care. And especially in the setting of severe BPD, linking inpatient with outpatient follow-up is so vital. And then finally, getting back to this idea of what to do, and this is work from Sani Arhans and Rolf Berger's group in Groningen, and they show nicely that in their population, again, look at this early mortality. We still have these challenges for the early stages. But with aggressive management, we could achieve resolution of their pH by echocardiogram and get these babies off pH-targeted therapies. But the idea is how to better identify these early babies, target their therapies, and knowing our goal is in part to look in the long term, this disease across the lifespan. So pulmonary vascular disease contributes to the pathogenesis of BPD and BPD-associated pulmonary hypertension. Primary management is the three spheres, but really entails a rigorous evaluation and treatment of the underlying lung disease. Ventilator strategies, as I suggested, that provide chronic respiratory support, quite different from what you do acutely with PPHN or CDH or others, may be important for the clinical stability and the improved survival and long-term pH outcomes in severe BPD. And then finally, pH and related cardiovascular abnormalities, LV diastolic dysfunction, pulmonary vein stenosis, and others are contributing significantly to the outcomes of our kids, and we need to be attentive to their presence. Then finally, we're grateful for all the great kids and families we've managed, and I also want to thank members of the PPHnet, as shown here, some of the sites. And it's been wonderful working with them to help develop some new thinking about how to think about pH and BPD. So thanks for your attention.
Thank you, Dr. Abnon. That was fantastic as usual. I'd like to welcome our next speaker, Michelle Beksinski, who will present to us on nitric oxide and pulmonary hypertension in premature infants. Thank you.
Good morning, everyone, and welcome again to our special session on challenges in neonatal pulmonary hypertension care. I'm a respiratory therapist at Sinai Health System in Toronto, Canada, and I have the special privilege of presenting my talk today on pulmonary hypertension and its considerations for the preterm population. I have no actual or potential conflict of interest in relation to my presentation today. Hypoxic respiratory failure is a common complication among preterm neonates, which can occur at various time points during an ICU stay. Clinically, HRF presents as an acute and severe impairment of gas exchange resulting from an underlying primary pulmonary or secondary non-pulmonary etiology. Although parenchymal lung disease and alterations in pulmonary vascular adaptation are inherent risks of prematurity and development of HRF, there remains a paucity of high-quality evidence to inform clinical practice. The majority of evidence to date in both term and preterm infants has focused on HRF during transition, and more specifically, acute pulmonary hypertension. So much so that in the context of prematurity, the terms HRF and PPHN are often used interchangeably. This is likely because HRF is seen to occur most often during postnatal adaptation and is therefore linked, irrespective of the underlying mechanisms at play. Pulmonary hypertension in the preterm infant poses a significant challenge to many clinicians, owing to the significant overlap in symptoms due to any or all of the following, including elevated pulmonary vascular resistance, low pulmonary blood flow, or parenchymal lung disease. In this presentation, we will focus primarily on HRF in the context of acute pulmonary hypertension crisis and its determinants in preterm neonates. With this introduction in mind, in today's talk, I intend to discuss details of what is currently known about the physiology of pH in preterm infants, starting with the natural history of pulmonary vascular adaptation, followed by the structural and biochemical differences including pulmonary vascular remodeling, parenchymal lung disease and the impact of ventilation, and lastly, the role of endogenous nitric oxide production and INO therapy and its controversies. Many of you have seen some variation of the image you see here, which shows the progression of PVR and SVR changes during fetal development and immediately after delivery, with units of vascular resistance plotted over time. As I'm sure you can appreciate, PVR is higher than SVR for the entirety of the prenatal period, with a gradual decrease from 20 weeks onward and reaching its lowest point around 30 weeks gestation before increasing again near term. The gradual decrease in PVR is attributable to vascular proliferation and a greater total surface area of the pulmonary vascular bed. The gradual increase in PVR later on is secondary to vasoreactivity of the pulmonary vascular bed to changes in oxygen. After delivery, SVR increases and surpasses PVR for the first time. A disruption in this process in the immediate postnatal period is commonly known as PPHN, a type of acute pulmonary hypertensive crisis. Though I intend to elaborate on the use of INO in the latter part of my presentation, I just wanted to share this graph here, which represents data from a U.S. network examining INO use stratified by gestational age. Having just seen the trajectory of PVR changes, it's interesting that the percentage of patients treated with INO is inversely proportional to gestational age, with the lowest usage observed at 32 weeks before increasing again towards term. A similar trend was observed in a recent paper from the UK Neonatal Collaborative, examining INO usage in English neonatal units between 2010 to 2015. Of the 4.9 infants who received INO overall, infants less than 29 weeks accounted for 31% of INO use. 51% were infants greater than 34 weeks, and the lowest usage was among those between 29 to 33 weeks, at 18%. In general, it was noted that there was also an overall increase in the proportion of infants receiving INO, with the greatest increase observed in those less than 29 weeks, as is shown here in the graph on the right. But more on this later on. But outside of inhaled nitric oxide use, and as I had alluded to earlier, delayed cardiopulmonary adaptation is an inherent risk of prematurity. The observed patterns of cardiopulmonary adaptation have been reported in a recent prospective cohort study of 58 infants born less than 29 weeks gestational age, whose pulmonary pressures were evaluated by serial echoes performed every 1 to 2 days for the first 14 days after birth. The cohort was divided into two groups based on echo findings at 72 to 96 hours of life. Normal transition was defined as pulmonary artery pressure less than 50% of systemic systolic blood pressure, and delayed transition was defined as anything greater than or equal to 50% of systemic systolic blood pressure. Using this definition, the incidence of delayed transition among this cohort of preterm infants was 55%, just over half. This graph represents the incidence of delayed transition by gestational age, and hopefully you can appreciate that there is an inverse relationship, and that less mature infants were more likely to demonstrate delayed cardiopulmonary transition. The cohort was further subcategorized in relation to subsequent development or sustained pulmonary hypertension up to 14 days after birth, as well as being categorized as having mild, moderate, or severe PH, using the definitions you see here. PA pressures were estimated using tricuspid regurgitation jet velocity when available, otherwise using the PDA gradient or systolic interventricular septal position in at least 2 planes. Using this framework, 5 distinct patterns were identified. The first 2 patterns are those infants who initially demonstrated normal cardiopulmonary transition. Those who did not subsequently develop PH and those who did were the 2 patterns that were identified. Conversely, those babies with delayed transition, the patterns which emerged included delayed transition becoming normalized, delayed and subsequently developing PH before normalizing, and finally delayed and persistent pulmonary hypertension. Among those with delayed transition, there was a greater incidence of premature rupture of membranes, lower gestational age, birth weight, and higher FiO2 requirements. Delayed adaptation was associated with an increased risk of death or BPD, independent of gestational age or presence of PH beyond 72 to 96 hours. What we can therefore conclude is that delayed transition is a common occurrence among preterm infants and may have important clinical implications. The next consideration is pulmonary vascular remodeling. Within the pulmonary vasculature, there are 2 key cell types involved in the regulation of vessel diameter, and they are endothelial cells, which make up the endothelium, and smooth muscle cells which surround it. Various chemical mediators like nitric oxide or endothelin-1 are released from the endothelium to act on smooth muscle cells to cause vasodilation or vasoconstriction, respectively. The term pulmonary vascular remodeling describes the condition when the number of smooth muscle cells surrounding the pulmonary arterioles increase in size or number, or spread to smaller vessels that are normally non-muscularized. The three major stimuli that drive vascular remodeling are inflammation, shear stress, and hypoxia. In utero, for example, these stimuli can manifest as a result of uteroplacental insufficiency, premature rupture of membranes, or fetal hypervolemia. In general, these infants may have an exaggerated response to hypoxia and acidosis following birth. Presence of pulmonary vascular remodeling may also have important clinical implications. For instance, this study, in which a subset of INO-treated preterm infants who died of HRF had their smooth muscle fibers evaluated on autopsy, reported a positive linear relationship between the severity of pulmonary vascular remodeling and the severity of respiratory illness. But pulmonary vascular resistance is not only affected by pulmonary vascular remodeling or vasoconstriction, it's also influenced by changes in lung parenchyma, in particular the application and titration of positive pressure ventilation. The schematic represents the size and shape of alveolar and extraalveolar vessels at different lung volumes. Areas of low lung volume, or atelectasis, cause compression or twisting of extraalveolar vessels, and conversely, areas with higher volumes or hyperinflation cause compression of alveolar vessels. In both cases, a net increase in PVR is observed. Preterm infants, owing to ventilation in the setting of surfactant deficiency and immature lung structure, which lead to acute lung injury physiology, relatively homogeneous lung recruitment to start with evolves into a heterogeneous pattern, resulting in areas of both atelectasis and hyperinflation. It can be challenging to both establish and maintain functional residual capacity for various reasons at different stages, and the result is elevated PVR. This graph represents the relationship between pulmonary vascular resistance and lung volume. Higher PVR at residual volume causes compression of extraalveolar vessels, and at total lung capacity, owing to compression of alveolar vessels. Here, the lowest PVR can be observed at FRC. Acute PH resulting from a disruption in transition from fetal to neonatal circulation is the most commonly described period of acute PH onset in both term and preterm neonates. Endogenous nitric oxide is a key chemical mediator during transition. The substantial increase in pulmonary blood flow precipitated by lung expansion after birth gives rise to shearing forces, which when exerted on pulmonary vascular bed, play a critical role in the regulation and production of endogenous nitric oxide, causing pulmonary vascular relaxation. Though lung expansion alone is usually sufficient to precipitate transition, the authors of this study sought to determine whether INO as an adjunct to resuscitation could improve ventilation perfusion matching and accelerate cardiopulmonary transition while reducing the need for supplemental oxygen in a group of preterm infants. This was a double-blinded pilot RCT of 34 preterm infants between 25 and 32 weeks who were randomized to receive an FiO2 of 0.3 and either INO or placebo as a part of resuscitation during the immediate stabilization period. FiO2 is titrated to maintain SATs within target according to NRP guidelines. Physiological parameters were measured over 20 minutes from initiation to titration and discontinuation of the gases. The primary aims were to determine whether adding INO decreased supplemental oxygen exposure and to compare heart rate, oxygen saturation, and need for intubation between the two groups. In this graph, the solid red and yellow lines denote FiO2 of the control and study group respectively. The dotted lines represent physiological parameters. The infants resuscitated with INO had a lower cumulative exposure to supplemental oxygen, a lower highest average FiO2, and lower rate of exposure to an FiO2 greater than 0.6 for the duration of resuscitation. All of the other physiological parameters were similar between groups, apart from a non-statistically significant reduction in heart rate for those resuscitated with INO. This preliminary study demonstrates that INO administration during resuscitation is feasible without adverse side effects and is associated with a decreased need for supplemental oxygen. Though these findings will need to be tested in larger trials, it suggests that INO facilitates cardiopulmonary transition at birth. In certain populations of preterm infants, there may be a transient deficiency in INO production soon after delivery. In this prospective study, whose aim it was to describe the risk factors of infants who develop HRF within 12 hours after birth and to better define the subgroup of preterm infants who would most likely benefit from inotherapy, tracheal aspirates were obtained from 144 infants who required mechanical ventilation and were analyzed for traces of nitric oxide byproducts. This box plot represents the concentration of metabolites measured from preterm infants with PPROM or sepsis who developed HRF within 12 hours and were subsequently treated with INO. What you can observe here is that nitric oxide metabolites were virtually undetectable before increasing following INO administration. But interestingly, nitric oxide metabolites were also undetectable in the aspirates of infants who did not develop HRF, born of mothers with preeclampsia. This suggests that production and regulation of endogenous NO may not be the singular determining mediator involved in circulatory transition. It may, however, involve a combination of factors, including, but not limited to, a transient deficiency in endogenous NO, causing dysregulated pulmonary vasoconstriction, and an underlying pathology which together exacerbate disturbances in ventilation and perfusion matching, provoking an acute pH crisis. Some examples may include RDS, pulmonary hypoplasia, congenitally acquired infection, and asphyxia. Conditions in which circulating blood volume is increased, such as twin-to-twin transfusion syndrome and fetal hydrops, may also be associated with acute pH crisis, secondary to pulmonary vascular remodeling that begins while in utero. Irrespective of the underlying mechanisms, the clinical phenotype of a failed transition is persistently high PVR, leading to pulmonary and to systemic channel shunting, presenting clinically as HRF. So what are the differences, if any, that we should consider when managing a preterm with HRF suspected of having pH? In addition to the basic and well-established principles of acute pH management in term infants, management for preterm infants is largely supportive, including treating the underlying pathology, providing it's reversible, with a potential role for specific pulmonary vasodilator therapy to treat endogenous NO dysregulation. The key principles of pH management can be summarized using ABCs, starting with airway, establishing a patent airway and a trial of non-invasive ventilation. An attempt to improve ventilation and oxygenation may be appropriate, with timely escalation to intubation and invasive mechanical ventilation for impending respiratory failure. The threshold for intubating a preterm neonate may be less, and though often occurring for the purpose of surfactant replacement therapy, the availability of less invasive techniques for surfactant administration may mean that intubation could be delayed, and so the need should be reevaluated on an ongoing basis. Next is breathing. The aim is to avoid areas of atelectasis and hyperinflation, which can compress alveolar vessels, causing an increase in PVR. Recall that PVR is lowest at FRC, so try to maintain alveolar recruitment using the lowest effective mean airway pressure. Also, optimal alveolar recruitment will increase the efficiency of ventilation and help to normalize CO2, which is important because acidosis causes pulmonary vasoconstriction and increased PVR, as well as intracellular acidosis, which may impair the function of cardiomyocytes. You'll also want to avoid large fluctuations in carbon dioxide and maintain targets within close range between 40 to 50 millimeters of mercury using lung protective ventilation strategies. When there is underlying lung disease, as is often the case in preterm population, it may be more challenging to clear CO2 in a minimally injurious manner, in which case there may be a greater role for high-frequency ventilation than in the term population. And if surfactant deficiency is suspected, prompt treatment with surfactant replacement to decrease alveolar surface tension is recommended. Last is to target normoxia. An SpO2 target between 91 to 95 is what we currently use at our center, and we know that hypoxia causes pulmonary vasoconstriction and may impair cardiomyocyte function, though hyperoxia does not confer any additional benefit and may cause harm. Last is circulation, monitoring for signs of systemic hypoperfusion in attempt to avoid metabolic acidosis, decreased venous return, and low pulmonary blood flow, which may worsen gas exchange and lead to further hypoxemia. Decreased blood pressure may also compromise cerebral blood flow. Establishing venous access quickly to manage fluid and arterial access for continuous blood pressure monitoring is key. Increased agitation may also increase PVR and metabolic demands, and therefore there's a potential for role for sedation and muscle relaxants. However, because of the potential for neurological side effects associated with the use of these medications, their judicious use is indicated. And of course, utilizing pre- and post-ductal saturation monitoring, noting that absence of a gradient does not exclude a diagnosis of pulmonary hypertension. In the last part of this talk, I will elaborate on the role of inhaled nitric oxide. The topic of INO use in preterm infants remains controversial, and though to date a number of studies have been conducted on the use of INO in clinically diverse populations of preterm infants, owing to the rarity of this disorder and a loss of equipoise among the neonatal community, a multi-center randomized trial is not anticipated. Differing findings regarding the effects on the most common primary outcome variable, death or BPD, has resulted in wide variation in clinical practice and some expert bodies discouraging its use in the preterm population. But these guidelines were not based on data addressing the impact of pH or reflecting real-world issues with pH management. But there is a divide between evidence and practice, and the authors of this paper published a few years ago also suggested three possibilities. One, that there is either a general lack of awareness of the evidence, two, a feeling that the evidence is not generalizable to a particular situation, or finally, that despite all evidence, due to a lack of an alternative, clinicians feel compelled to try to stabilize a patient using whatever means available. Also worth noting is that none of the large trials conducted to date required an ultrasound diagnosis of pH, which makes it difficult to rule out the benefit of INO in those infants with acute pH, and so there may be a role for INO use in this context. And though there is now a growing body of observational literature evaluating the efficacy of INO in the context of HRF when acute pH is suspected or confirmed, this is not always translated to a change in clinical practice. There was an interesting study conducted recently across centers in the US that evaluated the factors influencing decision-making surrounding provision of INO to preterm infants with pulmonary hypertension. They surveyed 304 neonatologists who were given a scenario of a preterm infant in 100% oxygen with echo evidence of pulmonary hypertension and asked if they would initiate INO or not. Their responses were interesting. 37% chose to initiate INO. 42 included parents in the decision-making, outlining possible side effects and cost, and 21% of neonatologists did not consider INO at all. Prior experience, safety, and patient-centered care were rated higher among those who chose to initiate INO, and lack of evidence and cost consideration rated higher among participants who chose not to consider it at all. As I previously alluded to, there is a growing body of literature from a number of retrospective studies published over the past few years, including one from our center in Toronto, reporting the outcomes of preterm infants with HRF treated with INO. For example, this retrospective study from the UK of 55 preterm infants with HRF and echo-proven pH who received INO, infants with a positive response to INO therapy, defined as a reduction in FiO2 greater than 0.2, demonstrated a higher rate of survival, 77%, versus those categorized as non-responders at 25%. At our center, we examined the outcome of 89 preterm infants with HRF receiving INO, 2/3 of whom had definite pH defined by echo or pre-postductal gradient, and we also defined a positive response as a reduction in FiO2 by greater than 0.2 within an hour of INO initiation. The result was an increased rate of survival among positive responders, 66% versus 29% in non-responders. We also examined long-term neurodevelopmental impairment at 18 to 24 months and reported that a positive response was independently associated with survival without disability, which was 51% compared to 15% in non-responders. In a separate study, we also examined the long-term outcomes of 53 infants born following pre-viable rupture of membranes less than 23 weeks as a marker of pulmonary hypoplasia, with just over half of whom received rescue high-frequency ventilation and INO therapy for refractory HRF. And after examining their neurodevelopmental outcomes at 2 years, we found no difference in the rate of disability as compared to those infants with PROM who did not have HRF. We did not have a control group as a part of this study. In this next study from the European INO Registry, INO response was measured among 69 preterm infants with pulmonary hypoplasia, and they found that an acute oxygenation response to INO, defined by a reduction in FiO2 greater than 0.15 within an hour, was associated with a significantly lower risk of mortality compared to non-responders. This recent study extracted data from a large US database, reported that in those infants diagnosed with pulmonary hypoplasia, the early use of INO did not improve survival in comparison to matched controls. However, when the infants were divided into two groups, pulmonary hypoplasia with and without pulmonary hypertension, there was a clear distinction. Those infants with pulmonary hypoplasia plus PPHN who were exposed to INO demonstrated a 33% reduced risk of in-hospital mortality compared to those who were not exposed. And in those infants with PH but without PPHN, there was no difference between those who were exposed versus not exposed. In general, there does appear to be a difference in the rate of survival between those neonates who demonstrate an improvement in oxygenation versus those that don't, such that withholding INO therapy altogether would seem unjustified. With all that said, in the last 2 years alone, there have been a number of reviews published on the topic of INO use in preterm infants, and can be summarized as follows. Inhaled NO use is not declining despite consensus statements and current evidence. This is likely because its role in acute PH is not well described. Guidelines from the American Thoracic Society, American Heart Association, and European Pediatric Pulmonary Vascular Disease Network have suggested a more balanced approach for INO use in preterms, that is, evidence of HRF, refractory to ABCs, and evidence of PH on echo. So to summarize, cardiopulmonary adaptation may be delayed in a large proportion of preterm infants. Antenatal and postnatal exposure to inflammation, shearing forces, and hypoxia contribute to the development of pulmonary vascular remodeling. Preterm infants may have a deficiency in endogenous NO production, which plays an important role in postnatal transition. Principles of pH management in preterm infants are comparable to term infants, apart from surfactant administration and oxygen saturation limits. In a subpopulation of infants with acute PH, therapy with INO may infer a survival benefit for those infants who demonstrate an acute reduction in FiO2, and a physiological approach, including early echo evaluation and optimization of ventilation and perfusion, should be undertaken prior to INO initiation. That concludes my talk for today. Thank you everyone for listening, and I welcome any questions.
Thank you, Michelle. That was very enlightening. I'm going to introduce our next speaker. We're a little bit behind time. Our next speaker is Dr. Amy Stanford, who's one of my colleagues here at the University of Iowa and part of our hemodynamics group. And Amy will be talking to us about hemodynamics guided ECMO care.
Hello, and thank you for allowing me to speak today on hemodynamic guided ECMO care. My name is Amy Stanford, and I'm a clinical assistant professor at the University of Iowa Stead Family Children's Hospital, and I'm also a part of our neonatal hemodynamic team. Since the 1970s, when neonatal ECMO was first used, almost 36,000 infants have been treated with ECMO. Respiratory failure remains the #1 indication for neonatal ECMO at 78%. Congenital diaphragmatic hernia, meconium aspiration syndrome, and persistent pulmonary hypertension are the most common neonatal diagnoses, accounting for almost 78% of all neonatal respiratory ECMO cases. Due to the improvement in neonatal care over the last 3 decades, the number of neonatal ECMO cases in proportion to all cases has declined steadily. However, the duration of ECMO runs have increased. Furthermore, survival has also decreased from around 80 to 85% down to 65 to 70% over the last 3 decades. These trends are likely due to fewer patients being placed on ECMO with reversible disease, such as meconium aspiration, and more infants being placed on ECMO who have a primary lung pathology, like ACD and inherited disorders of surfactant production, which have no effective treatments and are commonly lethal. Furthermore, in patients with severe pulmonary hypoplasia, including those with congenital diaphragmatic hernia, it can be difficult prior to ECMO initiation to determine which lesions are so severe to be incompatible with survival. Overall, the trends show that sicker infants are being placed on ECMO. While ECMO can be life-saving, there are increasing numbers of survivors having long-term consequences. Complications on ECMO include hemorrhagic and thrombotic events. Seizures are common in the neonatal ECMO patient and may be due to intraparenchymal abnormalities or related to illness and reperfusion injuries. In fact, we keep infants on ECMO on video EEG or AEEG during their run to monitor for this event. There are increased risks for cardiac complications, including arrhythmias, and commonly infants can become volume overloaded and may require dialysis. In addition, infection remains a concern during the duration of the run. As I mentioned earlier, the overall survival to discharge for infants on neonatal ECMO is around 72%. And of those infants, 10 to 25% will have mild to severe neurodevelopmental impairments. So it's imperative that we choose wisely babies who go on ECMO and try to avoid ECMO if possible. So here at the University of Iowa, our hemodynamic team is involved in the care of all ECMO referral infants. After an ECMO referral is received, there is an immediate hemodynamic consultation. And the main goals of our hemodynamic evaluation and our treatments are to 1, increase pulmonary blood flow, 2, preserve RV performance, 3, to facilitate systemic blood flow and organ perfusion, 4, to minimize tachycardia, and finally, we also want to make sure to exclude other etiologies of hypoxia, like seizures or effusions, which could, for example, lead to abdominal compartment syndrome. In most cases, we are able to avoid ECMO at our institution. But in some cases, the baby does need to go on to ECMO. But importantly, in either situation, the infant still receives continued hemodynamic care. When a baby is placed on ECMO, the hemodynamic team continues to monitor, evaluate, and treat. We are present during cannulation to assist with hemodynamic stabilization, and post-op to assess cannula position. During the run, we assess the infant about every 5 to 7 days, or sometimes sooner. Initially, we assess on full support to follow pulmonary pressures and ensure the physiology hasn't changed. During low flow trials, we assess pulmonary pressures and begin to get a gauge of the native cardiac function. We also assist in clamp trials, where we again assess pulmonary pressures, assess heart function, and the cardiac output, and we help make the determination whether they are ready to come off ECMO. And finally, before decannulation, after the clamp trials, we ensure that their hemodynamic medications have been optimized in order to have the highest chance of a successful decannulation. So let's run through an ECMO referral and the hemodynamic team's role and the treatments that we provided. This is a term baby who at delivery had hypoxic respiratory failure. He was intubated, placed on INO, and required 100% FiO2. He had a cardiology at 6 hours of life, which showed normal function with a small bidirectional PDA, with a mildly dilated and dysfunctional RV. Due to continued hypoxia, he was placed on the high-frequency oscillator ventilator, and his MAP was increased with no improvement in his oxygenation. And in fact, he was becoming more hypotensive. So he was started on dopamine of 5, which was increased to 5 mics per kg per minute, as well as being loaded with hydrocortisone. He continued to decline, so norepinephrine and epinephrine were added and titrated up to pretty high doses in order to achieve a blood pressure to, quote, reverse the shunt. At 12 hours of life, he was referred to our hospital for evaluation of ECMO because he had profound hypoxemia with SATs in the low 70s, despite INO of 20 and 100% oxygen. He also had supranormal blood pressures in order to, quote, reverse the shunt. He had evidence of poor tissue oxygenation with a lactate of 9.1, and he had dependence on tachycardia to oxygenate. So overall, a pretty typical ECMO referral. So as per our protocol, we assessed this baby with a hemodynamic assessment immediately after arrival. We found that he had suprasystemic pulmonary pressures with a small, almost exclusively right to left PDA. He had a dilated and dysfunctional RV with his fractional area change of 21 and a TAPSE of 5.7, both of which are low and abnormal. He had an OI of 54 and had consistently had an OI greater than 40 for several hours. So he was placed on ECMO watch, and at many institutions, I would wager he would be placed on ECMO. But in our case, we worked to optimize his hemodynamic therapies by utilizing a physiological approach to pulmonary hypertension. So we found that he was having low right ventricular output secondary to RV afterload mediated dysfunction. And he also had low left ventricular output secondary to poor preload and ventricular interaction. So we wanted to increase pulmonary blood flow by utilizing pulmonary vasodilators. We want to improve RV performance with positive inotropes and allow a pop-off with the PDA. We want to facilitate systemic blood flow and organ perfusion by restoring adequate diastolic blood pressure with systemic and not pulmonary vasoconstrictors in order to improve coronary artery perfusion pressures. And we also want to maintain ductal patency, which helps facilitate systemic blood flow. And finally, we work to minimize tachycardia so that we have time to adequately perfuse our coronary arteries. When utilizing a physiology-based approach to pulmonary hypertension, we really want to make sure that we're using the right drug for the right patient. And especially, we want to pick the drugs that have the most tolerable side effects. We always avoid dopamine in patients with pulmonary hypertension due to its effect on increasing pulmonary pressures. We may sometimes use norepinephrine, but it also still increases pulmonary pressures, but not to the extent that dopamine does. Our drug of choice is usually vasopressin because it has a good systemic vasoconstriction, but it actually decreases pulmonary pressures. For inotropes, we are mindful that epinephrine can increase pulmonary pressures, so we usually reserve that for cases of severe heart dysfunction, and instead tend to use either dobutamine or milrinone. Milrinone can be an ideal drug for many babies due to its effect on decreasing pulmonary pressures, but you do need to be mindful that it also causes systemic vasodilation and may need to be used with a systemic vasoconstrictor if you are worried about blood pressure. So back to our ECMO referral, who had an OI of 54 and suprasystemic pulmonary pressures with a dilated and dysfunctional RV. We worked to restore pulmonary blood flow and improve RV function. First, as soon as we heard about this baby, we recommended to add PGE, and they actually even started that before the baby got here. We next changed the dopamine and norepinephrine out for vasopressin. We then repeated our echo, and our RV function had improved, and we now had a TAPSE of 7.8, and we no longer were in a low cardiac output state and had an LVO of 141. We then added milrinone and weaned our epinephrine back to a lower inotropic dose. So when we reassessed this baby approximately 6 hours after arrival to our institution, our patient was on vaso of 1.4, milrinone of 0.33, epinephrine of 0.03, PGE of 0.03, And our baby was also down to 60% oxygen with good saturations in the 90s, an appropriate blood pressure, an appropriate heart rate, and our lactate had trended down from 9 to 2.3. We reassessed our patient, and on echo, he had systemic level pulmonary pressures with normal biventricular function and normal cardiac outputs. And in this case, like many others, we were able to successfully avoid ECMO. Sometimes, however, we were not able to avoid ECMO despite utilizing a physiologic-based approach. In this case, we had a term 36-hour-old infant with a left-sided CDH, who despite maximal hemodynamic therapy still had systemic pulmonary hypertension with a dilated and dysfunctional RV with a widely patent bidirectional PDA, who was on INO of 20, max dose of milrinone, epinephrine of 0.08 mics per kg per minute, continued on PGE, and his vasopressin was up to 2.5 milliunits per kilo per minute. Therefore, we determined that he required cannulation onto VA ECMO. Overall, our criteria from a hemodynamic perspective is that ECMO is only initiated when you have failed maximized cardiovascular and respiratory support despite maximized hemodynamic therapies. So as I mentioned before, if a baby requires ECMO, we continue to follow them throughout their course on ECMO. And I will walk you through some examples of our continued hemodynamic care throughout the run, and why it is important that we remain involved in their care. And overall, our goal is to maximize the chance of a successful ECMO outcome. So that same CDH baby, after cannulation, his INO was weaned to 5, and it was kept on due to the possibility of low-dose INO being shown in animal models to reverse pulmonary vascular remodeling. We cut his milrinone dose in half, and he remained on low-dose epinephrine, and his vasopressin was also changed out to norepinephrine. And overall, he was doing fairly well post-cannulation. However, that night, after cannulation, he had issues with his ECMO circuit. He was chugging quite frequently and required a lot of fluid in order to keep his circuits in good condition and running. In addition, he developed a significant gradient between his pre- and postductal blood pressures, and his urine output dropped off significantly. We were asked to assess his cannula position, as well as to see if his physiology had changed. And what we found was actually an extremely underfilled right atrium with a large, high-velocity, pulsatile left-to-right PDA shunt. So why did this happen? It's important to remember that you can have ever-changing physiologies even on ECMO. So normally, on VA ECMO, you have your venous cannula in your right atrium, and you have your arterial cannula in your carotid artery. And most of the time, you have a right to left shunt or a bidirectional PDA. But in this case, we had PDA physiology. And so, with this high velocity left to right shunt at the PDA, we were just recirculating blood from the left side of the heart, from the arterial cannula, right back to the lungs through the PDA. And we lost all of our right-sided preload, and therefore the right atrium was small and empty. And this was the reason why our circuit was chugging. Also, our systemic perfusion was affected because we had systemic steal with the PDA. And so therefore, our urine output dropped off and our postductal blood pressures were lower. So what we did to treat this was that we weaned our targets. We weaned our pulmonary vasodilator therapy slightly. We decreased our PaO2 targets. We slightly increased our CO2 targets, and we decreased our blood pressure targets in order to help modulate the shunt. And what we found when we reassessed this baby 4 hours after making those modifications we had a better filled right atrium with balanced circulation at the duct. And we no longer had any issues with our ECMO circuit chugging. He didn't need excess fluids anymore. Our urine output improved, as did our post-ductal blood pressures. As I mentioned earlier, we also monitor babies during their clamp trials to help assess if they are ready for decannulation. In this example, our patient was on ECMO day 14, and he had a planned clamp trial after having had a successful low flow trial. In preparation for the clamp trial, we recommended optimizing his hemodynamic therapies, including increasing our pulmonary vasodilators with INO and milrinone, supporting the RV function with a low-dose epinephrine. We always keep prostaglandin on for the entirety of ECMO runs for pulmonary hypertension so that we have a pop-off valve for the RV when we come off of ECMO. And we also restarted vasopressin in order to support our systemic blood flow and coronary artery perfusion pressures. With clamp trials, we do an echo immediately before the trial for a baseline, and then we repeat the exam when they have been on the clamp trial for around 20 to 30 minutes, depending on the baby and on the ECMO run. In this case, with these therapies, our patient had subsystemic pulmonary pressures with normal function and appropriate outputs. So we deemed him optimized for decannulation and that he had a good chance of a successful decannulation. Overall, our goals for hemodynamic care regarding ECMO are simple. For ECMO referrals, we use a physiological approach to therapy, and we work to optimize pulmonary blood flow, preserve RV performance, and facilitate systemic blood flow and organ perfusion. If our infants go on ECMO, our job is not done, and we need to assess the patients for potential for ever-changing physiologies. And we can also help to assess the readiness of our patient to come off ECMO and hopefully facilitate a successful decannulation by continuing to optimize their cardiovascular therapies. So overall, I hope that today you realize that hemodynamic care for our infants does not stop when they go onto ECMO, and that we need to continue to follow them and optimize their care throughout their ECMO course. I'd like to thank you again for the opportunity today to speak, and I look forward to any questions.
Thank you very much, Amy. That was a wonderful and such great guidance on hemodynamic responses with ECMO. I'll ask all of our speakers to turn their cameras on. I know that we're kind of short on time, and I'm mindful of the hour, at least for Dr. Patel, but we'll take the next 10 minutes to be able to go through some of the great questions that have come in. I'll start with Dr. Jain. A lot of discussion about the PDA and keeping it open in the setting of severe pulmonary hypertension. So this is really a twofold question. The first is, if you have a child that you have diagnosed pulmonary hypertension, but there's a small PDA and biventricular dysfunction, would you consider starting prostaglandins to kind of relieve that RV strain or pressure? And in that context, when you do something like that, how reliable is our classic echocardiographic measures of RV and LV output in the context of an open PDA?
Are you asking me to take that, Phil?
Yeah, it's all yours, Amish.
Right. I mean, it's a great question, to be honest. As Neil mentioned before, our criteria is pretty much similar to what Neil was suggesting for starting prostaglandins. In the context that you're describing, when the PDA is actually small and become restrictive, if there is a significant RV dysfunction still present, then we would not hesitate from starting PGs, even transiently, for a short period of time till we fix the physiology. But that would be the criteria, is to relieve RV dysfunction or progressive RV dilatation. Personally, I haven't had to do that a lot in non-CDH patients if you catch them early, because we are able to sort of manage their dysfunction before. But there have been occasions where we could not bring the pulmonary pressure down and the RV continued to get dilated. And just starting PGs within 12 hours, the RV function and the RV size actually recovers quite dramatically. So we would use that. But if the PDA is open, we will also not start PGs prophylactically because we can just monitor it. So that's one part of the question. The second part of the question was how reliable it is. But by reliability, I'm assuming you mean how the inter-rater reliability, the ability to measure it versus its accuracy, because they both are slightly different concept. The reliability of output measured on echo have been pretty much published many times, and they're pretty reliable as far as the inter-rater reliability goes. But does the reliability change in different disease states? That's never been studied separately. And you've given me a good idea to do a small fellows project actually. But I don't suspect that there would be difference, especially in the context of right to left PDA or bidirectional PDA or in PH. In patients who have a high velocity left to right PDA, I think it's a bigger problem. Is our RVO measurement really reliable? Because you get a lot of interference from the shunt itself, but not so much in PH patients because the flow direction is mostly right to left, or even when bidirectional is not high velocity enough to actually reach the pulmonary valve and affect the Doppler. We have actually, and Patrick knows this, we just finished a MRI validation study looking at 16 BPD PH patients and looking at their echo markers comparing to cardiac MRI. And that data should be published in the next few months, maybe. We will be presenting it or submitting it to PAS. We actually found very good correlation between both echo measured RVO and LVO compared to MRI measured MRI measured flow in the main pulmonary artery and ascending aorta when you do it by phase contrast. The QPQS on the echo actually correlated very well with the MRI QPQS with a very high correlation coefficient. Having said that, those patients did not have a PDA, except for one, which was small and restrictive. They were like the more older PH patients with ASD shunts. So I think I've tried to beat around the bush to your question if I tried that.
Thank you. That was wonderful, Amish. I'm going to let Adrianne kind of pepper Neil a little bit, make him sweat over there.
So Dr. Patel, one of the questions that came up for you on the chat is, can you comment on the hypothesis that LV disease in CDH patients could, at least in some part, be due to therapies which increase LV afterload? For example, the use of dopamine in an attempt to fix the blood pressure without adequate therapy to treat elevated PVR.
Thanks very much. Yeah, thanks Regan and Patrick for that question. I think it's an interesting hypothesis, and I think the answer is we don't truly know. There are some patients, in particular, probably the third of the cases that I showed you, that the nature of the LV dysfunction is so profound and is present really quite early on that initial assessment within the first few hours of life. I mean, I think there are definitely a group where there's this endogenous primary left ventricular dysfunction, but I would agree that I have a concern that some of this LV dysfunction is inadvertently mediated through our treatments, inappropriate treatments, either inappropriate use of vasoconstrictors, but more so, as was pointed out, this risk of driving a high heart rate and worsening diastolic filling, diastolic function, and coronary perfusion. Interestingly, one of the approaches that some of our colleagues use, Florian Kipfmüller and his team in Bonn in Germany, in the management of cardiac dysfunction, LV dysfunction, and CDH, is a combination of levosimendan. So they use that as an inotropic agent, it's a calcium sensitizing agent. And they combine that with a beta blocker to slow the heart rate down. And I think that's a really interesting combination, which hopefully they can report a little bit more on. I think what's probably less important than the agents that we might use and variation in the agents that we use is the principles. And the principle, I think, ultimately is support that left ventricle by positive inotropy, avoiding excessive afterload, and avoid high heart rates.
Thanks, Neil. That's wonderful to hear alternative ways to manage that LV dysfunction, because we know in the immediate period that could be troublesome, but in the long-term period, it's really the RV that can hurt us. We're running low on time, but I just wanted to preface, the 3 more topics I wanted to cover. The first is I'm going to ask Patrick just to talk a little bit about prostaglandin use in this population. I'm then going to shift over to Steve and ask him to really highlight when he switches over from RDS to BPD management with his ventilatory strategies. And then we're going to end with Michelle to talk a little bit about some of the benefits and risks of nitric use. And then all the other questions, we'll try and answer them over the next 5 minutes, and you'll see the responses. So Patrick, let's start with you, a little bit more about prostaglandin use.
So I think, Phil, there's 2 things. I think there's sometimes a looseness to the use of prostaglandin that I think is important to recognize. But I think ultimately one needs to decide what is your goal. Are you using it as an adjunctive pulmonary vasodilator, or you believe that one ventricle is in big trouble and you're trying to support whether it's the pulmonary or the systemic circulation? And I think there's an inherent danger that if you don't get that right in the wrong patient, you could actually potentially cause more harm than good. So our use of prostaglandin in the setting of pulmonary hypertension is very much we are strongly believe that the RV is in major trouble. And either one, you need to support the systemic circulation because there's really, really poor cardiac output. And in those patients, you need to maintain a right to left ductus shunt for some period of time, or one is trying to offload the RV itself. So what I would say is be cautious, think carefully. It's a great therapy in the right patient, but you give someone with biventricular dysfunction prostaglandin opening the duct when they don't need it, you could actually potentially cause a lot of QPQS issues for yourself that you don't necessarily need. And I think the case that Amy presented, the ECMO kid, just shows you that after you go on ECMO, you really need to think about flow across the ductus. It can, and I wonder how often does that happen, that you end up with QPQS abnormalities on ECMO patients that are managed with excessive amounts of volume, that people think it's just an empty right heart, but they don't actually know why the right heart is empty.
Yeah, that's really important to take into consideration. And really just shifting to Steve, the question in the chat was about when you would consider switching from an RDS type management to a BPD management and putting it in the context of what everybody else has talked about today.
Yeah, no, thank you so much. First of all, I just want to say again how fantastic these discussions are, such a high level, and what all of you have brought to the table, brought to the bedside, I should say, in terms of precision with managing and understanding their physiology, to me, so vital. And yes, I do believe in Cochrane meta-analyses, but I think there's a certain tyranny to the meta-analyses because we cannot get the MRCTs here. And it doesn't mean there's no evidence, but all the physiologic evidence from each of our speakers today is so striking and so strong, and you tested at the bedside, that I really think these are important lessons that we should carry forward. So as we think about ventilator management and transitioning from acute RDS to chronic lung disease, the physiologic basis is kind of simple in some ways. That is, early on with RDS, and this is true for ARDS in the older child as it is for RDS in the preemie, you have basically 2-zone disease, don't we? You have relative lung that you're maintaining some lung volume. It's not that it's a diffuse haziness throughout that's evenly matched throughout the lungs, but you have atelectatic regions, and then you have another part of the lung that you're ventilating off. And so being very careful to avoid ventilator-induced lung injury by having small tidal volumes, gradually recruiting that dependent lung or opening up edematous regions, and then, having used surfactants and everything like that to achieve that is so important. And so that's where the more rapid rates, gentle use of PEEPs as you try to achieve FRC, and managing small tidal volumes, I think there's a lot of wisdom to that approach, and that's great. But as you move forward, the physiology rapidly changes. It's dynamic, it's not static. So it's not either or. It's not either acute settings or chronic settings, but there is this transition. And that transition can happen remarkably early. In other words, there's evidence already that you could already begin to have regions of heterogeneity, regions of lung, and you see it radiographically, don't we? You see regions where they look a little distended, atelectasis, here and there it's patchy. And then if you maintain the wrong way of ventilating them, or maintain the strategy that it's still acute lung injury or acute RDS, we're at risk for simply emphasizing those hyperinflated regions become even more expanded at the cost of not recruiting the smaller lung zones. So it's that transitional window, and it's usually marked by persistent ventilator dependency, oxygen requirement. Radiographically, you start seeing more plate-like atelectasis or lobar atelectasis, and those are early signs that you should really rethink about how you're providing ventilator support. And it doesn't mean you suddenly go from 4 or 5 mils per kilo tidal volume to 10 to 12 and beyond. No, it doesn't have to be like a light switch. But you then start to think about increasing the tidal volume in your PEEPs a little bit and begin to think about having emptying time. But certainly by the time you're at 32, 34, 36 weeks, still ventilator dependent, invasive ventilation, or if you've been off the ventilator and you just seem to have a progressive chronic lung disease, to me, the overall philosophy of using the ventilator with larger, deeper breaths, slow it down, use PEEP appropriately, stepwise and gently, sometimes using bronchoscopy or other imaging to gauge how much is central airway collapse contributing. But then you could gauge the next steps. And you could do it incrementally. It doesn't have to be dramatic. But the one thing I wanted to leave with is they have to be done together, though. You cannot simply increase the PEEP and still have a ventilator rate in the 30s. You can't have enough exhalation time. You can't have a large tidal volume or inspiratory time with a high PEEP and still have too high a rate. And that's where we start to have this dramatic hyperinflation, sometimes with some regions more than others. So it's a transition, it's an evolution, the early signs are there. So make small changes in the ventilation and see what you could achieve with that. And I think to me, that the changes occur. And then finally, the philosophy of care. You're no longer worried about acute changes in PCO2. You're not worried about exactly what that PO2 is short term. You want to have a comfortable baby who's synchronizing with the ventilator and more of a gradual ability to tolerate sustained support so you could achieve your goals of decreasing the risk for pulmonary hypertension, perhaps, but enhancing growth and development and being able to be held and make eye contact with parents and providers and things like that. So more than you wanted to hear, I know, but it's a transition.
And just a couple of minutes to let Michelle also take the stage. Can you comment a little bit on the risks and benefits of INO for preterm infants?
Yeah, sure. So the safety profile for INO has more or less been established in both term and preterm infants. But with that said, we can consider the risks of INO in the context of both positive response and a non-response, or rather improvement in oxygenation or no improvement seen. So if we consider the first scenario where you have an improvement in oxygenation, then we've all seen preterms who've had a very dramatic response to INO. You kind of worry about the risk of the shunt becoming left to right, and owing to the fragility of the pulmonary vascular bed, you may see a pulmonary hemorrhage. So in those patients, it's important that you're extra vigilant, monitoring their changes in FiO2 and being ready there to wean the nitric or discontinue it if need be. The second scenario is when you don't have a response to nitric, which is commonly seen in acute pulmonary hypertension occurring later in the NICU course, and oftentimes secondary to neck or sepsis physiology. So here I kind of see two risks. The first is that perhaps clinicians can become a little bit tunnel visioned when INO doesn't work, and they perhaps may not look to alternatives to try to reduce the large intrapulmonary shunt. And the second issue may be that we don't know whether or not in these patients, because so little is known about the underlying mechanisms of pH that occurs later on, is whether INO may not be making things worse in that particular scenario. So those I would say are the main risks of nitric.
Thank you, Michelle. And I know the hour is late. I wanted to kind of thank all the speakers one more time. I just want to remind everybody that tomorrow, same time, we have a great series of lectures on the PDA. And then on Friday, the 19th, another great series of lectures on how all of this ties into the preterm and term infant with different pathologies. So with that, I again want to thank Amish, and I want to thank Laura Thomas, who's helped organize all of this, and the guidance of Patrick and Steve. Thank you and have a good night.